بسم الله الرحمن الرحيم. السلام عليكم جميعا. صباح الخير، مساء الخير, wherever you are. Uh, my name is Abdelkader Chaar. I'm a member of the SAMS Education Committee. I've been with SAMS for about 10 years now, and was part of these kind of workshops for some time. We're very happy to have you. Congratulations on your match and on starting this kind of a new journey in the US. We are very happy for you, and we hope you will get to know more about you today, and we'll hope that you guys will benefit from this session. This is our annual Essentials Bootcamp for the incoming residents to the US. We try usually to cover kind of a basic kind of high level summary of how things look, what things to look for, and what can you do to shine as an excellent intern. We have an excellent set of panels, all dedicated to helping you guys and for medical education. So we're gonna have 2 days. Today we'll have two sessions. The first session is going to be about understanding U.S. residency system and expectations. The second session will be about clinical documentation workflow efficiency. Next week, we will have 3 sessions about academic growth and career planning. Then we're going to talk about wellness. And then finally, we'll close with an open space with experiences with current interns. So we're very happy to have you guys. And without further ado, we'll go ahead and start with our first speaker. Our first speaker is Dr. Shams Albachir. She graduated from her medical school from Al Faisal University in Saudi Arabia. She is currently a rising PGY2 internal medicine resident at St. Vincent Hospital in Worcester, Massachusetts. She has a strong interest in endocrinology, medical education, and mentorship. She's passionate about helping others, giving back, and making transition to the U.S. residency more transparent for the coming years. She hopes to help you becoming a better resident, understand the structure of the U.S. training system, and begin your intern year with more clarity and confidence. So without further ado, I will pass on the mic to Dr. Albachir. Shams, go ahead. The floor is yours.
Hi, good morning, everyone. I'd like to, first of all, start off by thanking SAMS for giving me this opportunity to be here with everyone. I'm very grateful and excited for all of you. I'll start off, first of all, by sharing my screen. Just a second. All right. I know that the title of this talk sounds very official. It's Introduction to the U.S. Residency Training, and I want to make this practical. I'm still close enough to intern year, and I remember exactly the confusion that I felt at the beginning of intern year. So I'm not going to give you a textbook version of residency. I want to give you the version that I wish someone gave me before July. I'll be expanding more on what the words mean that you'll be hearing in terms of the scheduling and all, where you will be fitting in as an intern, and what people actually expect, and how to start safely without pretending that you know everything. I have my email in the corner here for any questions after the session. So the hardest part about this residency was not actually the medical knowledge, especially when I first started. I thought if I read enough and knew enough, I'd be okay. But then I realized that the stress comes from something else. It comes from learning the system, like who do I call, what is urgent, what can wait, and how do I really sign out safely? Where do I find the policy? When do I escalate if something is concerning? And this is what I really want to focus on today. Before we get into the structure, I want you to take a second and think about what really scares you most about July. And my goal is not to make that fear disappear. It's just to give you a map so that the fear and the anxiety becomes more manageable. So, where do you fit in the hospital as the intern? This is the first mental model that I want you to have. The focus in the hospital is the patient. As an intern, your job is not to carry the hospital on your back. Your job is essentially to gather accurate information, write safe orders, and recognize when the patient is changing. Communicate clearly and make sure that you always close the loops. And I'll expand more on what closing the loops means. Your senior resident is there to essentially help you prioritize. They've been there, they've done it before, they know what's important, what's urgent, and what's not. They help supervise you, and they also usually run the team. And then you have the nurses, and I believe the nurses are the most important because they are at bedside all the time. They know exactly when changes happen before anybody else notices it. We also have the pharmacists who help us with dosing the medication, noticing if we've ordered drugs that interact with other drugs as well, and they make sure that the patient is receiving medication safely. If you have any questions about dosing, what the right medication to use, it's always the pharmacist who's there to help you out. Now, the next part of the team is the case manager. I did not personally have much of an exposure to case managers back in Saudi, so this was completely new to me. In the US, they got to make sure that the patient, after their discharge, they go somewhere safe, whether that is to their house, to a skilled nursing facility, to a physical rehabilitation center, and so on. So the case manager is the person who's going to help you arrange that. They also take care of insurance issues and so on. Other hospitals have social workers who also help in that, but it really depends on your hospital and program. And then we have the consultants. They're the team that you usually consult to help you manage a specific problem, like cardiology, for example. And they gave you their focused expertise in managing that specific problem and what they recommend. And then last but not least, the patient's family. Always keep them involved on a daily basis, tell them what's happening, update them, let them know what the next steps are, answer their questions, and then make sure that you build that trust with them. And then when it comes to the PGY ladder in real life, it really depends on which specialty you're in. Like, for example, the internal medicine, it's 3 years only. PGY1 is all about safety. You learn about your patients. You always ask early if there's any concerns, and you should make sure to write safe orders, double and triple check, especially in the first month. We all make mistakes, and that's okay. But what's important for you is to notice that mistake. And that's why I'm stressing so much on safety. And then the fourth most important thing in PGY1 is to close the loops. Like, for example, if a task comes up in rounds where they ask you to speak to one of the consultants, make sure that you speak to the consultant and get back to the rest of the team on what they recommend. I know it sounds very simple and very easy to say, but unfortunately not everyone does that. So it's at the end, it's what's going to set you apart. Now, as you're done with first year and you've honed down your skills and acquiring those important information like history, physical examination, knowing the system, knowing who to contact, knowing where the policies are, knowing where the order sets are, knowing the EMR. Then comes PGY2. PGY2 comes with a little bit more responsibility, actually much more responsibility, and it's all about ownership. They know how to prioritize problems. Their task is to supervise interns and make sure that every order is placed safely and that every patient is stable. They are the ones who usually anticipate next steps based on their expertise in the first year. And they usually should be teaching their juniors while they're doing their job. And then we have PGY3, and it's about leadership. They lead teams, they mentor the juniors, and they essentially prepare for being an independent, either fellow or attending, depending on what their plans are after residency. Now, the mistake here is to think that independence means acting like you do not need help, but it's actually the truth is that you earn independence by showing people that you know your limits and that you always escalate at the right time. So what intern year is made of? Again, it depends really on the specialty that you're going on, but just generally speaking, there's the wards, and that's where you get exposed to basically patients from the moment that they're admitted, and then you take the history, the physical examination, you order the investigations, you make sure that those investigations are being done and that the patient is getting treated, and that you round on the patients, make sure everything is fine, you speak to the nurses, you coordinate with other teams, you update families, you follow up on consults, and you plan discharges as well. In the ICU, things are a little bit more fast-paced. It's more immediate, and you learn essentially what it means, how to differentiate between a really sick patient and a sick patient in the wards. And then when it comes to clinic, you learn continuity in how to manage chronic diseases essentially, and preventive care and vaccination and cancer screening and so on. On nights, so for example, in my program, we have an intern that does admissions and then an intern that does cross-covering. I didn't know what cross-covering meant when I first started. Cross-covering basically means that you are taking care of the patient, of every other team's patient. And that does not necessarily mean that you're actively managing them. You're just responding to any acute things that happen at night. Like, for example, one of the simplest things is that they cannot sleep. So you just try to see if they're taking anything at home that they use to sleep. And if it's safe, then you can administer that to them. Other more serious things would be, oh, the patient is requiring more oxygen. Then at that time, you have to go and assess the patient and make sure that they're stable and so on. So this is cross-covering. Admitting is basically any patient that comes into the ED, and then you intend to, as per the attending's plan, if they want to admit them, then you go do the history, physical labs, and so on. And then electives is what is your opportunity to think about your future. It gets you exposed to the subspecialties that you can further go into after residency. And then lastly, Jeopardy. Jeopardy is not there in every program. In my program, we don't have that, but it's usually where you are covering for the case that if somebody falls ill, like if one of the interns or residents fall ill, then you would be called into the hospital to cover for them. So, I mean, the details again vary by each program, but the core habits stay the same. Make sure that you know your patients, you communicate early, and that you follow up on what you start. And always ask if you're worried about something. Just a quick view of what a normal day looks like on the wards. For example, it's not just notes. It does sound simple, but it's easy to underestimate how many loops you create and how many loops you should be closing by the end of the day. you start off with pre-rounds, and then you round, and then you make a work list during the round of the tasks that you should be doing. And then you recheck, make sure that you got everything done. And then that's when the day starts moving. And for example, like one of the things that could come under your work list is consults. And consult is not done because you paged or because you placed an order for a consult. A lab is not handled just because you ordered it, and a medication is not given again just because you ordered it. Um, your skill that you should be able to hone down at least within the first couple of months is to follow through and make sure that the loops that were open in the morning should be closed. I know it sounds boring, but it is one of the fastest ways to become trusted as an intern. Now, the next thing is call schedule. It creates a lot of anxiety because everyone uses them slightly differently. Long call usually means later coverage or more admissions. Like, for example, if a ward shift day is 12 hours, from 6 a.m. to 6 p.m., the long call would be coming in from 6 a.m. to 6 p.m. A shorter call would be a smaller admission window or earlier stop time. That means they come in at 6 a.m., but they leave by 2 p.m. And then the team that was having the long call would continue taking admissions until 6 p.m. I hope that makes sense. The next thing is night float that we spoke about before. It's essentially a block where your shifts would be at night, so from 6 p.m. to 6 a.m. And then cross covering, which I explained in the last slide, it's covering patients that you might not know well because they're covered by other teams. It doesn't mean that you'll be rounding on them. It's just covering anything that comes up in the day or night. And then jeopardy, which is the backup coverage when someone is out. And then your day off is essentially your time away from any clinical work based on your schedule rules. But the main advice in here is simple. Just don't hear someone else at another hospital like tell you their schedule and then assume that yours will be identical. It really differs between each program and the other. And if you have any uncertainty about a specific term, ask your program. I believe that orientation is coming up, so I'm sure that they will walk you all through what it will look like. Now, the next thing is how much will you actually work? Now, duty hours are not just paperwork essentially. They exist because unfortunately fatigue does affect patient care, and I'm speaking from personal experience. Not only a patient care, but also our well-being as residents. The big number that people know is 80 hours per week, but it's averaged over 4 weeks. Any clinical work that you do from home also counts up to these hours. Any long continuous clinical work should have limits. And programs usually track time away from clinical work. And your job is to log your hours honestly. And then the maximum scheduled continuous clinical work is usually limited to 24 hours. And that includes the additional time that's for transition from team to another. And you should have at least 1 day per week off. Now, ACGME without the boring part, you don't need to memorize their policies. You just, I just want to give you what the practical meaning of what ACGME is. It's essentially the guardrail behind your program. They are the ones who influence the supervision, the evaluation, the duty hours, the learning environment essentially, and your well-being as a resident. You do not really like you should know that the training has standards, and that you should have supervision and you should be receiving feedback, and you should have a structure for evaluation, and you should not feel like patient safety depends on you pretending that you're not tired or struggling. And then how do they decide if you're doing okay? The milestones are basically how programs think about the residents' development. The 6 big areas are patient care, medical knowledge, professionalism, communication, systems-based practice, and practice-based learning. In real life, people are actually asking, is this person safe? Do they tell the truth? Do they improve when they're given feedback? Do they communicate clearly, and do they follow through? And one bad day that you have is not the story on what you are as a person, but repeated habits unfortunately do become the story at the end of the day. So what will July actually feel like? And then I'm gonna say the quiet part here. It's going to be uncomfortable. It's a new environment, new people, new skills that you'll be expected to learn, but you will be feeling slow, honestly. You might open the chart and not know where to start. You might get a page and feel like your heart rate is jumping. You may feel like everyone else understands the language of the hospital except you. And then that is normal. Everyone felt like that. We've all been through it. And the goal in July is not to be fast immediately, but the goal is to be safe while you are slow. Because being slow is going to be fixable. The more that you repeat those tasks, the faster you at it. Just make sure that you're being safe. And if you're uncertain about anything, make sure that you bring it up and ask. Because if unfortunately hiding the uncertainty is dangerous. By the end of the first month, you may not feel completely confident, but you should at least feel less lost and better at knowing when to ask for help. So, what is an intern who people would trust? I think that this is the heart of my talk today, but we have a session coming up that will expand on what the expectations are. I just wanted to mention this, that the intern that people trust is not always the intern who knows the most in terms of medical knowledge. It's basically the intern who calls early when something feels wrong, who tells the truth when they do not know, who answers pages promptly, and who communicates any delays that would affect patient care. And lastly, but not least, the most important thing is closing loops. You don't earn trust by acting independent and making it look like you know everything. It's if a patient is getting worse, call. If you're confused by a result, ask someone. And if a nurse is worried, take it seriously, because they've been there much more than we did. And people can teach you medicine, but they need to be able to trust your habits first. So what is the game plan going to look like for your first month as an intern? Build simple systems. First thing that you need to do is learn the map. Who's going to be your senior? Who's going to be your attending? Where can you find the policies and order sets? And secondly, build your system. Make sure that you're able to create a task list and a pre-round routine. For example, in Onwards, I would print out the patient's list and I would write letters like N for notes, O for orders, F for family, and then S for sign out. So every time that every time I finished the note for someone, I would tick off the notes box. Every time I place all the orders after rounds, I would tick the orders box. And then on the back side of that paper, I would fold it into 8 boxes because the cap in our hospital is 8. And then with each box, it would have a patient and then the tasks that I have for each patient. And then the other parts of the system that you should be building on is your pre-round routine. It took me, I think, until December to be able to build a routine that's efficient for me, and that's okay. But at least start at something that you think would help you become safe but efficient at the same time. And then the last thing is ask before the rotation ends about feedback. You can ask them mid-rotation, what should you improve? What are you doing well, and what should you do differently tomorrow? Trust me, this is gonna help set you apart because it shows that you want to learn and become better. And don't wait until the last day to ask for feedback. People do respect residents who want to get better. I want to end with this. Your first month is not about looking perfect at all. It's about becoming safe, honest, teachable, and easier to trust every week. There will be uncomfortable days. There will be moments where you feel behind. That doesn't mean that you do not belong. You've done all the work. It just means that you're learning a new system, and that's completely fine. Nobody has extremely high expectations, and everyone has been through your footsteps now. And just make sure that you build your safe habits because they come first, and then trust comes next, and then confidence will follow later. Thank you for listening, and I'm happy to take any questions.
Thank you so much, Shams. Excellent summary, mashallah. Allah yajziki al-khair. So for questions, if you guys want to write them down in the chat, or after this session, we will have a Q&A session. You can participate, you can write, send a chat, and then we'll have the panel to answer questions. So just for the sake of time for now, we'll move on to the next speaker, and then we'll do the Q&A later. So our next speaker is Dr. Jihad Alharash. He is an attending physician in internal medicine. He's a co-director of medical student program at Cook County Health. He's an assistant professor of clinical medicine affiliated with the University of Illinois in Chicago. He is a dear friend and a proud member of SAMS for more than 15 years. He served on many committees and boards, both in educational and medical relief. Dr. Jihad is a member of our education committee and helped building a lot of these programs that you guys participate in over the years. So we are very lucky to have him with us. And the floor is yours, Jihad.
Assalamu alaikum, everyone. Can you see the slides? I don't know. It's
yes, sir. Yeah.
Okay. Okay. Voice is okay, right? All right. So let me just fix this. A quick peanut hour. طيب يعطيكم العافية جميعا. Anybody does not speak Arabic? Because I'm gonna speak Arabizi. So if anybody doesn't speak Arabic, please mention so we stay with English. Thank you, Dr. Chams, for the very good presentation. You made my job much easier. And thank you, Dr. Abdelkader and Dr. Hussam for working on this. It's very it's a privilege for me to participate in this activity. سلامات يا شباب يعطيكم العافية. Welcome everyone. I just want to say thank you all for being here. It is the time that you are being a doctor. First of all, I'm sorry for the خنة الصوت شوي. I'm a little bit sick. بس الحمد لله we are meeting on Zoom, not in person. So this is the time that everybody has been working on for like years now, right? Alhamdulillah. Yani after all this work that you guys did, finally you are gonna be a doctor. Not now yet, maybe 2 more weeks. It's exciting. It's very exciting. So please remember that the way that that everything you have been working on for all this time, now alhamdulillah you are seeing the fruit of that, and you are going to be starting on the floors in the clinics to be a real doctor. I was asked today to cover the topic that what the attendings look for in the residency program. It's when they evaluate you, when they talk about you, when you finish every rotation with every attending? What's their impression about you, and how can we make this experience more successful and in, help you to proceed to the next rotation successfully um, after working hard? So remember, I wanted to um, remind you why you will be evaluated in every rotation. We have here in America, the system is the ACGME, the one who does the training programs. When they start uh, all those programs, they make sure that they produce independent doctors that they can practice on their own. This is the point. For those who applied for license, on the meeting, they know that when you apply for license in any of the states, ما حدا بيسأل, nobody asks for a board passing or board certificate. Most of the time, especially in the first time when you apply for license, they are just asked for training program. For the SCGME, it's very important that they produce people who are able to practice independently, that they can give them their patients safely without being concerned about any safety issues. For the program directors, it's a little bit different because they they measure the success of the program directors based on the passing board scores. And that's a question we get to ask a lot. Why, for example, during the match season, program directors are very picky about the scores, for example, because they look at the scores as a sign that you will be able, when you pass your USMLE is high, then you'll pass your boards high, then their program will continue to function, will continue to be credentialed. But if at some point the board passing rate goes under certain level, the program stops at some point. So they give them like warning, they give them like kind of, they put them on certain levels of warning, but eventually they stop funding the program, and the program director considered failure to him if he not able to achieve certain passing board scores. For the hospital system and the attendings, obviously patient care is the priority here. So when I am on the floor, I'm having new residents, I want to make sure that my patients are safe and we succeed as a team. That's the important role here. And that's why you will hear it a lot that oh, now July, August started, Allah Store, we have new interns, new people coming, and we need to figure out a way to make sure that everybody is safe. All of us were in your shoes at the point when we started training, and it is stressful like what Dr. Shams said. Yes, يعني عندكم كتير تحديات, but at the same time, to me, it's exciting. It's really exciting that after all this time that you have been studying so hard, taking exams, or going for like kind of elective rotations and doing research. Alhamdulillah, you are at this point, you are starting your training. This is the time that you really expect to see how your real life will be as a doctor. So Alhamdulillah, يعني be excited about it, and يعني have set your expectation. When you set your expectation right, that makes things much easier for you. So what makes an excellent resident in general? When most of the interns are asked this question, they say that, oh, the medical knowledge, clinical reasoning, procedures, those kind of things that work so hard to do. Are there, my job today is to show, is there any important ones that people are not aware of? At least people when they start, they don't focus a lot on. Yes, they are. In general, for the ACGME, when they evaluate the residents, they enforce actually every program to have something called clinical competency committee meeting that happens twice a year, once every 6 months, and to evaluate the progress of the residents, to look at every resident, how they have been doing. Are they meeting their milestones? Are they showing the correcting the mistakes that they have? Those meetings are required by every program to do. The meeting usually happen between the program director, the associates, the leaders of the program, with some of the attendings, and they involve people as needed. Again, if you notice here, I highlighted this part that it is they want to make sure that the you reach out to the level 4 of on your training career, training in the program, to reach out to the point that you are practicing independently, at least to level 4. So when attendings meet with each other and talk about every resident, they ask questions during this meeting. Is this resident progressing appropriately? Are there any concerns? This is a big question usually. يعني especially in the first few months, nobody's gonna look at your how much better you are doing, but they just want to make sure that there's no red flags. And the red flags we're going to talk about in a few minutes. But is there any procedures needed that to correct those red flags? And then eventually, by the end of the year, they want to make sure that by the end of your residency, that you are able to function independently. The ACGME core competencies, Dr. Shams went over those quickly, and I'm going to touch base more on those. The patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and system-based practice. So when they evaluate each of the student of the residents, they have the attendings, basically the main ones who evaluate. For me, at the end of every rotation, before I sit with the resident and I talk to them, I sit with the other team members to ask them about that person. I ask the co-interns, I ask the students, I ask nurses how this person is doing, and many times you get to know a lot about every resident based on this network around them. That's why every person in the hospital or in the health system that you are working at is very, very important. You have to be professional. You have to show the perfect communication skills. And believe it or not, the medical knowledge here does not rank one of the top ones. يعني اللي بدي أذكركم فيه يا شباب إنه you are at the point right now that programs already accepted you. They already know about your CV. They know that how good you are. They know that you scored very high in USMLEs. They know that you did this rotation, this and that. يعني medical knowledge at this point, it does not matter, especially in the first few months of the residency. What matters is how reliable you are, how communication skills you are, how team player you are, and how can you apply the accountability of being a professional physician. So the when attendings discuss those issues, they considered like important, like certain features as a positive signs about any resident, that this is a resident that always follows through, that like when we meet every day, we say that this is a patient that we need. Let's say that patient with kidney problem, coming with potassium. I'm telling my resident, listen, this is a patient that we need blood work for this patient right after. I need to have nephrology be consulted right after rounds. I need to develop the trust that this person who's working with me is gonna go ahead and follows through all the orders, all the discussion items that we have discussed during the rounds. And I always tell my team that you have the right to disagree with me as much as you want during the round, but after round you cannot disagree with me. Because during the round we disagree, we argue, we discuss. I convince you, you convince me. We come up with a final decision, but this final decision needs to be applied. That's how I build my trust in you as my resident or my intern or even my student after I work with you. And The worst part here is if this trust get broken, or if you do not gain this trust easy, it will take longer time. But sometimes if you gain it early, you keep it. So يعني مثل ما بيقولوا the first impression when you meet with someone, or when you work with someone, always remember a bit about this first impression. You want to show them that you are the reliable person that is trustworthy, that when I work with you, I ask you, what did you do for this patient in terms of physical exam? Did you listen to their chest? If you didn't get a chance to do it, just tell me, I'm sorry. This was like a very busy morning. I didn't get to see this patient. I didn't listen, I didn't hear their heart sounds. The last thing you want to happen that the attending go to the patient and on physical exam find, for example, has like a foot ulcer. When you told them that I already checked their feet and there's no problems, no issues, or any other finding. Be honest and be reliable. Be honest about the past and reliable about the future, meaning that whatever happens before, you have to be honest about have you checked, or what did you check about any patient, what did you do for in terms of history, exam, all of those, and you have to be reliable about whatever you agree on, that you go ahead and apply it right away. It's very important to be the person who is easy to work with. Again, you are spending the time in the hospital more than what you spend time with your family. They want to make sure that the environment in the hospital between the team members, it's friendly environment, it's healthy environment. You need to be happy. With all the stress and anxiety that you are going with starting your internship year, you have to find a way to be happy and enjoy it. If this doesn't happen, honestly speaking, the years of training will turn into hell for you. يعني هتكون صعبة جدا جدا. بينما if you set your expectations, if you know that I know it's gonna be difficult, but that's what I signed up for. That's what I want to do. That's what it's gonna make me a better doctor. Seriously, no matter how difficult the program you're gonna be at, you will enjoy it and you will be happy doing that. Just set your expectation. The attendings usually are very happy when each team member, they know their deficiencies and they ask for help when they need it. They want to make sure that people do not just take risks on their own without bringing it up. إذا بتعرف إنه it's difficult for you to put an order, or you're not sure, there's no silly question. Always ask. All the residency programs are very supported because they don't want to put their reputation, or they don't want to go to the court because of a mistake that a resident or intern do. So all of them are they have system like what Dr. Hasham said, that you will have a hierarchy. You have your senior resident, you have chief resident, you have a fellow, you have attending. All those people are there to help you. So always ask for help when you really need it. Do not hesitate to do it. Do not hesitate to do it. The ownership of the patient is very important part. Is we need to make sure that when you have a patient, you are the person who knows the most about this patient. You need to make sure that when you talk about the history, you know all what happened before. The more you do, you are able to do those parts, the better of physician you will be. I will go a little bit faster because I know that some of the slides having some repeating terms. So again, what are the good signs that when you are on the floor that reflects positively on you? You have to make sure that you show up early, prepared. You are taking full ownership of your patient. You know what happened with them. You know what happened in the past. You know what happened last night. You know. About sometimes you need to know about their personal life, how they live, who support them at home, who helps them take medication, all those kind of information. It makes you stronger resident in front of the attending and in front of the team when you talk about your patients. Follows through, we already talked about. Communicates clearly, accept feedback. We will talk a bit about feedback in a minute. And support teammates, what make you a team player. Reliability, to me, this is the most important feature when I start with rotating with anybody. I tell them I want to reach out to a point that I trust you. When I tell you that we are doing this to the patient, you're doing it, I need to have the confidence that you are doing this. When we agree that you need to call the family and discuss certain items, when I see that we need to call certain consult, make sure that you are closing all the loops if there's any deficiencies. If for example, you asked to order some labs, and then they told you that the phlebotomy person is not here, you make sure that you close the loop, you call somebody else, you ask the nurse to do it. That's what closing loops is. That's what make you reliable, make you that we are sure that you are having the job done. The professionalism, I know that Dr. Osama Tayyar will talk after about the professionalism, which I know that he's much better speaker. So please make sure that you attend his lecture and listen to it carefully. Professionalism in general is the one of the items that people report a lot about, and it's easy reportable deficiencies with if people have problem with professionalism. And in general, it is the area that people from different background, from different practices, they do not share necessarily the same ways of practicing medicine. So it's very important that you follow the hospital protocols, and you show the respect to all team members. Here, for example, Dr. Shams also mentioned this, the nurses is big deal here. You have to make sure that you're respecting them very much. You have to make sure that you're respecting co-workers, respecting all patients. The accountability, you take responsibility on your actions. The integrity that you are practicing medicine in the best way, that best honest way. You have to be humble and show the best of your ethics. This is professionalism is very important in this area, and it is an area that again you will see a lot of studies, a lot of case reports regarding doctors, even on attendings levels, they have professionalism issues. So it's very important that you follow the codes on the professionalism. Communication skills is an area that you can basically, when you improve your communication skills, you can cover any error happen in the hospital. If you have problem with your medical knowledge, if any mistake happen with your communication skills, you can cover that. Make sure that you start strong with your communication skills in your residency. You want to make sure that when you are rounding with an attending or with the senior residents, wherever happens, that you have good communication with them. If you are late, we should not be late, but if you are, if something happened, that make sure that communication is closed with every team members. You have to make sure that you communicate with your nurses about your patient plans. You have to communicate with your consultants, even with your patient about their plans. That's the way that every problem in the hospital, I mean, different hospital has different systems, but they find ways to correct their mistakes through the communication skills. Teamwork, again, we want to make sure that you are not practicing solo, right? The residency is the best example for teamwork, that you need to succeed as a team. And believe it or not, your attending will know that even if when you're working as a team, they will know that you are putting so much effort to make the team succeed. You want to make sure that you co-intern doing their job. If there's some deficiency, it's okay to step in and show that. Do not make it in a way that you just want to try to show off and tell them, oh, this patient, you are talking about your co-intern patient, and you try to show that you know more than you co-intern. No, try to support them. Try, if you feel that they have any problem. And everybody will notice it, and people will appreciate it, that because of your teamwork skills, the whole team is succeeding. You want to make sure that whoever handle having any problems with the stress, with anxiety, that you are showing the support for them, so all the team succeed as a together team. Teaching is an area is very important, especially in the programs that you will have medical students at. أنا بشوف at the end of every rotation, I do ask the medical student about their resident. How are they treating you? How they're teaching you? And remember, the teachers are the best learners, because whenever you are teaching, you have to learn yourself, so you don't don't look bad, right? So كتير كتير مهم يا شباب إنه إذا عندكم medical student, take care of them. That's the time that you used to be a medical student like a few months ago, and now you are a resident, and they're gonna be resident soon. You need to make sure to show them the support, and you do not show them that you're neglecting them or they are extra burden on the team. And always, whenever you showing good teaching to the team, even to other co-interns, that reflects very positively on your relationship with attending. Those are the same characters that I mentioned: reliability, professionalism, teamwork, communication, ownership, growth mindset, and clinical competencies. The green, I mean, when you have those considered are green lights on your pathway through the residency. When you take ownership of your patient, you have the teamwork mentality. When you sit with your attending, they give you feedback. Make sure to listen to them, reflect about their feedback, and work on those points. Because next time they work with you, they bring it up again, and they want to see that if you show progression or no. That's how we evaluate our resident, and that's how we decide if they are working on their deficiencies or no. And then uh, situation awareness, this is the last field. That's how it differentiate the senior resident from the intern. It shows that this is a resident that knows who are the sick patients, who has the full picture about what's being ordered, what's being pending, and they expect which problem might happen with every patient and what might go wrong, because they know which are the sick patients. This you will develop through the 3 years of training. The faster you develop this, the better you show as a leader in your team. So try to gain this skill. It's not easy skill to gain, but the more you work, the more detail oriented you are, the better you will be. You don't want to be the person who kind of deny their deficiencies. All of us here having deficiencies, including attendings, including fellows, and all of us here in training programs to work on those deficiencies. So make sure that you admit your deficiencies and tell them that, yeah, I'm working on this. Make sure that you follow on the orders, like as we mentioned about the reliability. You don't want to have professionalism issues, because again, those are issues that easily reported. When something happened, everybody will know about it. So do not fall into the professionalism problem. And make sure that you are self-aware of your level, and so it enables you to work on it. So when you achieve all those major areas, the competency, reliability, professionalism, and communication, that's when you will gain the trust of the attending. When I was preparing the slides, it just came to my mind the AI, which right now everybody is working on, like ChatGPT. And did it make any of those different? Honestly, it make the medical knowledge much easier, because right now you do not have to memorize all those guidelines that we used to. You don't have to even if you are lacking some medical knowledge, it's so easy to open your chat GPT or to up to date, or you open your phone. But if you have professionalism issues, if you have communication problem, when you will not be able to cover that. So please make sure that you work on these areas, and make sure that you show that you are working hard to correct any deficiencies you have in those 4 areas. Remember that because of the evaluation, if you're attending, you will work in more in autonomy and more in more comfortable space, because now they start trusting you more. You will have better evaluations that makes you proceed to the next level, to your fellowship, to your career in easier way, because evaluations are stronger, and your letter of recommendation will be stronger, and leadership opportunities happen because of this. Um, Multiple times for me, when I see impressive resident I really like, and I feel that this is a resident that have like this skills, I take an extra step. Once I went to program director and they told them, listen, this resident is amazing, make sure to take him as chief resident. I was not requested to do this, but I felt that this resident has to take the opportunity. and I went and I took extra step. When people see that you are working hard and you are covering those areas, they appreciate it a lot. Um, that's how you succeed, and that's how you become very well known. I don't know if Dr. Naeem, one of the speakers, I think he should be one of the speakers today or next week. But Naeem started in our president in our hospital. He's amazing. He's amazing. So because they love him so much, they when he recommended taking his wife, they took his wife, and his wife did very good job. Next year, when she because she did very well, they took his brother as the resident. He did amazing. Now they took the brother as chief resident. I mean, they took the whole family because of somebody starting doing very good job. And this happens, like there are so many similar examples in all hospitals. So please make sure that you show all the good work that you have, work hard, and people appreciate it. And sorry for being a little bit taken over time. Thank you so much.
Thank you so much, Jihad. Excellent talk as usual. Allah yajzik khair. If you guys want to write down your questions, feel free to use the chat, or we can later take questions in the Q&A session. We're for the sake of time, we'll just move on for the next talk for now.
I will post on the messages my email. Anybody have any question, you can email me. I might need to go for a round in the hospital, so I might not be able to stay for the QA. So I'm sorry. I know that all of you guys are here. Yeah, if there is anything, anybody wants to like email me personally, please feel free. Otherwise, yeah, I'm sorry, I will not be able to be for much longer time.
No worries. الله يعطيك العافية جهاد والله يجزيك خير. شكرا جزيلا. Yeah, we can connect with you, and hopefully we can all help answering together if any questions. So our next talk is about professionalism and work ethics in the US, and our speaker is Dr. Osama Altayar, who is another dear friend of mine. Osama is an associate professor of medicine in the division of gastroenterology at Washington University in St. Louis. He graduated from Damascus University in 2011, and then after that, he did a research fellowship at the Evidence-Based Medicine, Evidence-Based Practice Center in Mayo Clinic. He then completed his internal medicine residency at Allegheny General Hospital in Pittsburgh, and his GI fellowship at Washington University in 2019. He also has a degree in biomedical informatics. He currently serves as a faculty member and associate professor at Washington University, where he continues to practice and teach. He is a member of our SAMS education committee as well, and has a lot of input on how these workshops go, and always helps us and participate and organize, and I personally learned a ton from him over the years, so we are very lucky to have Osama with us.
شكرا عبد القادر. Thank you for the invitation. هي هو يعني بتسمعوني كويس ولا لا؟ My voice is clear.
تمام ممتاز.
Good. Thank you for the invitation. دائما it's always a pleasure to be here. وما بظن إني حكون أحسن من جهاد. I don't think so. هيك قال بس I don't think so. Okay. Can you see my slides well?
Yeah, all good.
Good. Okay. طيب أنا هحاول أحكي بالعربي. هحكي بالإنجليزي لما يطلع شوي إنجليزي. هحاول أحكي بالعربي قدر الإمكان. أول شيء مبروك جميعا. أنتوا عملتوا أصعب خطوة، يعني بعد الميديكال سكول أصعب خطوة هي الريزدنسي، بس دخلتوا بالريزدنسي عملتوا إنجاز كبير. يعني هذا الإنجاز ما تخلوا أي شيء ياخذ فرحته منكم وانبسطوا فيه. وهو الشيء اللي بيحدد حياتنا للمستقبل كله إن شاء الله. الشيء اللي حأحكي عليه هو البروفيشناليزم والورك اثكس. البروفيشناليزم الاحترافية وأخلاقيات مكان العمل باليو اس ريزدنسي بالتحديد. هذا الشيء مثل ما حكى جهاد، هذا الشيء ما بيتغطى بمناهج، هذا ما له منهج. هذا الشيء له علاقة بثقافتنا وله علاقة بثقافة مكان العمل. هو ما له حتى موضوع بس لبس، شو بنلبس أو شو ما بنلبس. هو له علاقة بمعايير معينة تم تعريفها عبر الزمن. رح حاول استخدم معايير ECGME قدر الإمكان، والشيء الثاني هو حاول استعين بشوي قصص تاريخية لحتى اشرح يعني كل فكرة إن شاء الله. طيب، وين حنروح؟ حنحكي على 5 شغلات. حنحكي عن شو يعني الاحترافية بالنظام الأمريكي. رح نحكي عن جهاد اوريدي حكى على شوي، بس حنحكي على عادات يومية بنعملها ممكن يعني تغير كيف الناس توثق فينا كليا، أو ممكن تخلي الناس توثق فينا دائما. حنحكي عن الديجيتال فوت برنت تبعنا على السوشيال ميديا، وكيف ممكن يأثر علينا وعلى الهبة. حنحكي إذا صار معنا مشاكل أو كونفليكتس كيف نتعامل معاها. وحنحكي شوي على مواضيع سياسية حتى، وكيف كلاتنا ممكن نتعرض لها أيضا، الخلاف السياسي. آه وحنحكي كمان إذا يعني لا سمح الله صار معنا مشكلة كيف ممكن نتجاوزها. أهم شيء تذكروه إنه أنتوا أو نحن يعني كلاتنا، أنا منكم، كل اللي عم يحكوا اليوم أعتقد منا كلنا، نحن ما عندنا سلم واحد ونحن عم نتعلم، عندنا سلمين عم نطلع عليهم. السلم الاول هو سلم الريزدنسي نفسه، الاديوكيشن. انت بدك تتعلم تكون طبيب، كيف بدك تعالج وكيف بدك تشخص وكيف بدك بس وكيف بدك تكتب التشارت وكيف بدك تعمل ديفرنشال دايجنوز، كل هالشغلات. هذا الشيء انتم الطلاب نحن والطلاب الامريكان او اللي دارسين بامريكا عنا يا نفسه بنمر في نفسه. آه، الشيء الثاني الخاص فينا نحن، وهو بناء على دراسات حتى، هو في عنا سلم ثاني كليا، هو بدنا نتعلم قواعد مكان العمل. بدنا نتعلم، في عنا learning curve تاني بدنا نمشي فيه، هو البروفيشناليزم، كيف المكان بيشتغل. نحن عم نتعلم ثقافة طبية، كيف ثقافة التعامل مع المرضى، كيف بيحكوا الزملاء مع بعض، كيف نحكي مع المشرف، كيف المشرف ممكن يكون عم يراقبنا ونحن عم نحكي. يعني أنا بس حاط كم مثال هون أنا. انه مثلا ممكن يكون يقول لك حدا انه اتس فاين، انت تقول لحالك اوه ممتاز، قال لي انه انا فاين. نو، اتس فاين احيانا معناتها مو اتس فاين، معناتها انه بدك تشتغل اكثر. بس هي اللانجوج استخدموها. ممكن كيف نحكي مع الناس بالعمل، مين نسأل، مع مين، لما إذا بدنا نصعد كيف بدنا نصعد، كيف نختلف مع التانيين بطريقة صحيحة بدون ما نعمل مشاكل. آه الشيء المهم كثير الأهم إنه هذا الشيء ممكن نتعلمه. صح، هو عبارة عن ثقافة ولكن ممكن نتعلمه. شغلات تانية بتصير معنا نحن كثير. أعتقد إنه هو يعني في فرق الثقافات بيأثر. مثلا في ناس ثقافات معينة بيكونوا كثير مباشرين بالحكي. هذا الشيء مباشر بالحكي ما يعتبر وقاحة أحيانا. أعتقد نحن السوريين بشكل عام عندنا مشكلة ثانية يعني. ومو مشكلة، عندنا نمط ثاني من التعامل، هو الاحترام. نحن بنحترم الشخص الأكبر منا، بنحترم الشخص السينيور إلنا. هذا الاحترام اللي كثير أحيانا ممكن مثلا البعض يعتبروه نقص بالثقة. طبعا هذا مو مشكلة، ولكن هي بدنا نعرف الكالتشر حتى نعرف نتعامل معاه. مرة ثانية هي قواعد ممكن نتعلمها وبس تصير واضحة لنا. هذا السلم الثاني ما بيعد مشكلة اللي عم نحكي عليه، السلم العلمين بصير كل شيء بدنا نركز عليه هو التعليم الطبي. بس بالأول، لذلك مثل ما قال جهاد، أول كم شهر فيهم صعوبة دائما. أكيد كلنا بدنا نتعلم تعليم طبي، بس أهم شيء نتعلمه هو نتعلم ثقافة المكان وثقافة التعامل بالمكان الطبي. جهاد كمان حكى على هذا الموضوع. جهاد حكى انه على البروفيشناليزم. البروفيشناليزم ما هي شغله انه والله انت اتيكيت، والله هي هذا شخص محترم ولا مو محترم، لبسه حلو ولا مو لبسه حلو، لبسه مرتب او لا. هي كومبتنسي، هي كومبتنسي. لما نحن بنقيم اي متدرب فيلو ولا ريزيدنت، في عندي 6 شغلات بدي اقيمهم عليها. في كيف بيتعاملوا مع المرضى، كيف بيتعاملوا مع كيف الميديكال نولج، البراكتس بيزد ليرنينج، هالشغلات. بس واحدة منهم هي البروفيشناليزم. يعني هي معيار بيتم تقييم المرضى بيتم تقييم الريزيدنتس والمتدربين عليه. طبعا مو بس شغله تدريب، يعني مو انه هي شغله نتعلمها بالتدريب بعدين ننساها، هي حتى كطبيب، اي طبيب لازم يكون بروفيشنال بالسيستم. طيب، شو تعريف الاي سي جي ام اي؟ كيف الاي سي جي ام اي بيعرفوا البروفيشناليزم؟ عده شغلات. واحد، compassion, integrity and respect. يعني الرحمه والنزاهة واحترام الآخرين. يعني نحن لما بنحكي مع أي مريض، احتمال يكون مريض أحيانا تعبان، ممكن يكون متضايق كثير، ممكن يكون موجوع. ممكن هذا المريض يكون موجوع يقوم يحكي بطريقة شوي قليلة أدب، أو بشكل ممكن نفهمه نحن قليل أدب حتى. يعني بالنسبة لنا كثقافتنا نلاقيه قليل أدب. مو معناته انه نحن بنصعد، بالعكس نحن we have to show compassion، لازم نظهر الرحمه دائما، ولازم نظهر التعاطف معهم دائما. فهذا كثير مهم. الشيء الثاني انه نحط حاجه المريض على راحتنا الشخصيه. يعني احيانا والله انا اسهل لي اني اروح اعمل النوت، او اسهل لي اني اروح اعمل شغله. احيانا بكون شغله صغيره، بيقول لك المريض والله انا بردان، روح جيب له حرام دافي. يعني هذا مهم. يعني شغلات صغيرة كثير ما بتاخذ وقت كثير، ممكن تساعدنا كثير انه نظهر بروفيشنال والناس تشوفنا بروفيشنال اكثر. آه، accountability to patients and to the profession. accountability يعني المساءلة، يعني انه نكون نحن مسؤولين عن كل شيء بنعمله. يعني النوت تبعوتنا دقيقة. يعني انا بشوف احيانا، طبعا هذا الحكي مو بس مننا نحن، من كل الريزيدنتس، بشوف ريزيدنتس والله عم يعملوا كوبي للنوت من النهار اللي قبله، منسوخة من النوت اللي قبله، عم يعمل كوبي 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 كل يوم. مثلا شو الكوبي بيكون محطوط فيها؟ مثلا الفحص السريري. شو الفحص السريري؟ والله المريض انتبيتد، المريض عامل له تنبيب وعلى المنفسه. اوكي. طيب المريض طالع من الاي سي يو صار له 5 ايام، لسه كل العالم عم تعمل كوبي فورورد انه انه انتبيتد. هذا مشكله، ما انا اكيوريت نوتس. هي ما أنا يعني انت you're not being accountable you do this. يعني كل شيء انت بتكتبه انت مسؤول عنه، وكل شيء انت بتحطه انت مسؤول عنه. لما مثل ما قال جهاد، لما تقول انه you're gonna follow up، لما حدا بدك تعمل شغله you're gonna follow up on it، رح تكمل وراها. continuing learning طبعا جزء من مسؤوليتنا نحن، جزء من الاكونت انه نحن نتعلم. يعني انا بشوف مريض بشغله ما بعرفها، جزء من الاكونتبيلتي تبعيتي اني اروح اقرا عنها واحاول اعمل بلان. هذا جزء من الاكونتبيلتي. شيء ثاني respect for privacy and autonomy. يعني كيف نحترم خصوصية الناس، خصوصية المرضى، وحريتهم بأخذ القرارات. يعني نحن هون كثير ما بنمارس في طريقة الممارسة الأبوية بالطب، إنه لا أنت لازم تعمل هيك. لا، كثير أحيان ممكن المريض، أنا امبارح شفت مريض عم أعمل له منظار كولون، عملنا له منظار كولون. بعد منظار قبل منظار كولون قال لي أنا ما بدي أي عملية جراحية. قلت له لحظة صلي على النبي، لسه عم نعمل كولونوسكوبي، أنت جاي يعني بالأساس نعمل كولونوسكوبي؟ فقعدت فهمت منه هو ليش خايف. هو ما بده عملية جراحية، ما بده إلا بطنه مثلا. انا ما بشق بطن، انا بعمل كولونوسكوبي. بعد ما خلصنا شخصت له سرطان. بعد ما شخصت له سرطان، عمل له المريض انه طلع معك سرطان وكذا. قال لي انا ما بدي اي كيموثيرابي. قلت له يا ابن الحلال صلي على النبي، لسه ما يعني لسه هلا رجعت الريزلتس، انا هلا عم اقول لك لسه ما عندي نتائج الخزعه. بس انا بالاخر قلت له كل شيء بدك اياه هو اللي حيصير بالاخر، كله خياراتك انت. ما في شيء حنعمل لك اياه انت ما بدك اياه، ولكن خلينا نشوف شو التشخيص اول. خلينا نعمل الصور شعية لحتى نقرر شو الستيج تبع الكانسر، وبعدين نمشي عليه. بس كثير مهم انه نحترم البرايفسي تبع المريض، اوتونومي. طبعا هذا المريض اضطريت اقعد معه اكثر، يعني انا بس هو جاي يعمل له كوناس، اضطريت اقعد معه اكثر لاشرح له يعني افهم، لانه عنده اختلافات بيني وبينه، او بينه وبين النظام الطبي. فانا مو والله رحت ignored it وقلت له خلص بس تشوف الدكتور تبعك. لا، I have to respect his privacy, I have to respect his autonomy كمان، واشرح له كل شيء واتاكد اني انا وجهه بالطريق الصحيح. الشيء الثاني الكالتشرال اويرنس. مثل ما هلا في كالتشرال اويرنس، يعني هذا المريض انا عم احكي معه، عم قلت له ليش، يعني بس انه انت عم تجاوبني بسرعه كثير، هل في شيء انا ممكن يعني انا ماني عرفانه عنك؟ هل في شيء؟ قال لي انا اختي ماتت بسرطان وكان اخذت كيموثيرابي، وهي بالكيموثيرابي تعبت كثير كثير، وانا ما بدي مر باللي هي مرت فيه. قلت له خلاص ما تخاف، احنا اكيد اللي انت حتمر فيه حنمر فيه. احيانا في مرضى، يعني امبارح قاعد مع صديقي انقاذ طبيب اورام. فعاده انت بدك تفحص مريضه، مثلا بدك تعمل فحص ثدي لمريضه، بدك يكون معك شابرون، بدك يكون معك مرافق بالغرفه. ولكن قال لي انه في كثير مرضى بيطلبوا انه ما يكون في شابرون، احيانا ما بدهم يكون معهم مرافق. طبعا هذا الشيء هو cultural. هو يعني he has to respect their culture. يعني هن ما بدهم حدا يشوفهم ثاني، انه أنا خلاص جاي اشوف الدكتور، بس بدي الدكتور حصة، ما بدي حدا ثاني. فنحن ممكن نفكر انه لا دائما بده المريض شابرون، لا، ممكن المريض يكون ما بده، ممكن المريض يفكر بطريقة ثانية. وطبعا تختلف، ان نحن نشوف مرضى بثقافات، حتى يعني مرضى يعني من نفس المكان بثقافات مختلفة، بدنا نعرف نتعامل معاهم كلهم. آم، موضوع الاحترافية، في يعني هي أول شغلة حكيها شغلة تاريخية. في شيء اسمه كلمة لاتينية اسمها equimitus. ويليام أوسلر في له كتاب اسمه equimitus. هذا الكتاب هو عبارة عن كل الخطابات اللي أعطاها للريزيدنتس وقت التخرج. ويليام آسر هو الشخص اللي عمل نظام الريزنس، يعني هذا نظام الريزنس كلنا مش فيه، هو تصمم من خلال هذا الشخص بجونز هوبكنز. فبهذا الكتاب هو حاول يعرف سمى شيء كوميونيتس، اللي هي معناها رباط الجأش. هي معناتها رباط الجأش، معناتها الهدوء والثبات الانفعالي. تمام، انه كيف لما نكون نحن تحت الضغط انه نضل ثابتين. هذا جزء كثير من المهم من البروفيشنز، بنحكي عن الاحترافيه. الاي سي جي ام اي عملوها ميجربل، عملوها شيء مقيس. تمام. شو هي جزء احد تعريفات البروفيشناليزم اللي مقيم عليها كل ريزيدنت لما يجينا. كيف بيكون واحد وصل اعلى سكور بالبروفيشناليزم؟ it means that they are demonstrating professional behavior in complex or stressful situations and learning to head off a lapse before it happens. شو يعني؟ يعني انه هذا الشخص بيظهر سلوك احترافي بالمواقف المعقده والمجهده. يعني ممكن يكون يعني مريض عم يموت، او مريض او شيء بالاي سي يو، عم نعمل سي بي ار وكذا. هذا الشخص بيحافظ على رباط الجأشه، بيحافظ على احترافي، سلوكه الاحترافي دائما. والشيء الثاني هون انه they can انه learning to head off a lapse before it happens. بمعنى انه اذا شاف في حدا في زله عم تصير، في حدا حيعمل خطأ او حيعمل شيء سيء، انه ينتبه عليها ويقدر يمنعها قبل ما تصير، سواء بحاله او بالاخرين. يعني يحس حاله انه والله انا عم توتر، ممكن يعمل شيء غلط، ممكن يسيطر على حاله. هذا هي رباط الجأش اللي حكى عليها ويليام أوسلر. وهي جزء من البروفيشناليزم، انه كيف نضل دائما سواء نحن ونحن مرتاحين ولو نحن تعبانين، how to stay professional. طيب، اول شغله هي الموثوقيه، reliability. يعني هي اهم شغله، هي العمله تبعتنا، هي الكرنسي اللي نحن بنستخدمها. يعني اذا انا دائما بفكر لما بدي اشتغل مع ريزيدنت، هل هذا الريزيدنت بوثق فيه او ما بوثق فيه؟ ما بس مع الريزيدنت، حتى مع زملائي بالعمل. في زملاء انا ما بوثق فيهم، وفي زملاء بوثق فيهم. في زملاء اذا انا عم موت بدي اياه يعالجني، وفي زملاء للاسف انا I don't trust them مثلا. تمام. بس كيف انا لحالي طلع معي هلا، انا شفت شغلات، في شغلات سمول هابتس صغيره انا شفتها بهذا الشخص، او هي الشخص كل يوم خلتني افكر فيهم انه انا I can't trust them. طيب، شو امثله على الشغلات؟ في عنا البنكشواليتي. يعني ما حدا حيقول لك ليش انت جاي بكير. كثير صعب حدا يقول لك ليش انت جاي بكير. آه بس اكيد حدا حيسالك ليش انت جاي متاخر. يعني اذا انت جاي متاخر، اكيد في حدا حيسالك ليش جاي متاخر. بس انك جاي بكير، والله انت جاي عم تعمل بري راوندز، مثلا راوندز بتبلش او الدوام بلش 7 وانت بتعرف حالك لسه جديد بالرزدنسي وبطيء شوي بالتعامل، تقوم تيجي بتقرر تجي بكير. ما حيقول لك ليش جيت بكير، جاي عم تشوف المرضى بكير. لا بالعكس، arrive early دائما، بلان خليك تكون دائما قبل الوقت. حسابك انك توصل بالوقت. المورنينج ريبورت ببلش الساعة 7، خليك هنيك الساعة 6:50، 6:45. إذا ناوي تعمل بري راوند اعملها قبل حتى. هي عبارة عن احترام، هذا جزء من احترام الناس. reliability، يعني إذا حدا، هي جهاد حكى عليها، إذا حدا قال إني أنا حاعمل شيء، أو الاتندنج قال لك أوكي خلينا نشوف اللاب شو حيصير فيها، أو قال لك الاتندنج أوكي حاكي الراديولوجي خلينا نشوف شو طلع بالسي تي سكان، لما حكينا هيك انت حتروح تتابع على هالموضوع، انت ريلايبل، وتعمل ريبورت باك للاتندنج في لوب كلوز. شو يعني لوب كلوز؟ لما انا بقول لك تعمل شغله يو ريسبوند تو مي، بتقول لي انه انا اوكي عملتها وهيك النتيجه كانت. كلوز ذا لوب اولويز، دائما كلوز ذا لوب. صح، انا قلت انه هي ما بس على الدرس، بس الدرس مهم. يعني في عنا شخص كان باحد التدريب اللي عملته بالريزدنسي وبالفellowship، كان عندنا شخص دائما لابس سكرابز، دائما لابس سكرابز على العياده، سكرابز على الراوندز، سكرابز على البروسيجرز، سكرابز. فالناس يعني يججب انه هذا الزلمه دائما بيجي بالبيجامه. هاي الكلمه اللي بتنحكى عليه دائما، انه هذا الشخص دائما بيجامه. يعني حتى اذا كان في حفله واجا لابس طقم جراف، الناس تضحك عليه انه اوف قررت ما تلبس بيجامه اليوم. فدائما كون يعني دريسد اب، دائما كون فورمال. اذا ما انكم متاكدين والله انا لازم اكون فورمال او ما فورمال، يعني شوفوا اطلعوا فوق بشوي. الشيء الثاني، انتم بتطلعوا على الغرفه بتشوفوا شو الاجواء، في ناس عم تلبس فورمال ولا ما عم تلبس فورمال وبتمشوا عليه. بس دائما اذا شاكين مو غلط انه نكون فورمال. يعني انا بيرسونلي انا بالراوندز دائما لابس قميص وتاي مثلا دائما. بشكل عام. لما بروح على العياده دائما قميص وتاي. لما ببروسيجرز بلبس سكرابز، بس احيانا ممكن نروح بقميص وتاي عادي يعني. بس ما نكون اندر دريس، فحاول نكون دائما انه لبسنا نظيف انيق مكوي. هذا الشيء بنعمل جادجمنت عليه للاسف احيانا اذا الواحد ما منتبه. الشيء الثاني، في شيء بنفكر فيه نحن انه انا ريلايبل، انا بهتم بالمريض، انا بخلص كل شيء. احيانا ممكن نكون تعبانين، احيانا ممكن ما يعني عم نعمل شيفت مثلا 24 ساعه ومجهدين، او انت حاسس حالك مرضان وانت حاسس حالك مرضانه ومانك قادر تشتغل. مهم كثير تو ادمت فتيج، نقول انه انا متعب ومجهد ونخبر الشخص المسؤول عنا. ليش؟ هلا احكي لكم ليش بعد بشوي. بس لانه ممكن يصير شغلات خطر على المريض اذا نحن ما انتبهنا انه نحن مجهدين، ونحن ممكن ناذي حدا لانه نحن متعبين وما عم نعمل برفورمانس جيد، ممكن ناذي مريض. فلذلك دائما السيفتي اهم شيء. المهم بكل هاد كله انه هي تكون هابتس عنا، يعني مو انا يوم بجي بكير يوم بجي متاخر، يوم انا ريلايبل يوم ما بجي ريلايبل. هي الريلايبلتي اللي عم نحكي عليها، هي الموثوقيه اللي عم نحكي عنها، هي بتنبنى مع الوقت. انا اذا هذا الشخص كل يوم بشوفه كل مره بحكي معه، انا في فيلوز لما بكون اون كول بيتصل علي بيقول لي هذا المريض بده منظار، ما بسأله أي سؤال بروح بعمل منظار. في فيلوز بيتصلوا علي بيقولوا لي بدي أعمل منظار لهذا المريض، بسأله مليون سؤال، بسأله مليون سؤال لأني أنا I don't trust them مثلا. فهي مشكلة. ليش؟ لأنه they're not reliable for me. They didn't build the reliability habit with me. آه طيب الشيء الثاني اللي هو العلاقة هو الكوميونيكيشن، إن نحن نتواصل باحترافية كل الوقت. يعني إذا حدا بعت لك تكست إنه والله let's round at this time, respond immediately. respond، أو قول أنا حخلص هالشغلة بهالوقت. مثلا حدا قال لك أوكي أعمل هالشيء، أوكي أنا إن شاء الله I'll report back on this by 2 p.m. تمام. اذا حدا بعت لك او انت عم تبعت ايميل وحدا بعت لك ايميل، خلي السبجكت واضح، خلي السبجكت مكتوب بشكل صحيح، بشكل بروفيشنال، بشكل احترافي. مو والله كلمات كبيره في عالم احيانا تعمل كل شيء اول كابس. ما كل شيء اول كابس، هي اول كابس عاده بيستخدموها اذا حدا بده يحكي. احيانا في عالم بيكتب كل شيء اول كابس او كذا. وكمان هي من السيجنالز اللي ننتبه عليها. ممكن حدا يكتب لك شيء اول كابس معناتها متضايق منك. اذا التاني كتب لك شغله عم يوضح لك شغله انه ندير بالك على الشغله. نكون الايميل قصير، ما نكتب ايميل طويل، يكون ستريت فورورد. تحدد مين انت. يعني انا احيانا بتصل علي ريزيدنت بيبعث لي رساله، او حدا يبعث لي رساله انه والله هاي دكتور كذا، انه انا عندي هذا المريض، وبيحط لي مثلا احمد. مين انت يا احمد؟ انا ما بعرف مين احمد اساسا. شوف في مليون ريزيدنت عنا، انا كيف؟ فحط الرول تبعك مين انت، وحط الكونتاكت باك تبعك، انه انا كيف بدي اتصل عليك مثلا. انه اذا بدك عندك questions call me to this phone number. البيجينج، لما بتعمل بيجينج لحدا او بتتصل على حدا او بتبعت لحدا مثل عم اقول على سكيور شات، مين انت وليش عم تبعت. بس انا هاي انا ريزيدنت فلان الفلاني، بتصل عليك بهذا المريض، هذا المريض عنده هي المشكله، وشو السؤال اللي عندك اياه. ننتبه كثير وقت نحن عم نكتب بالتكست وبالمسجنج. وهذا الشيء حتى مع رفقاتنا بيصير. احيانا ممكن نكتب رساله تنفهم غلط، صح؟ فلما عم نكتب رساله وممكن حاسين انه ممكن تنفهم غلط، اسهل شيء بينعمل ارفع السماعه واتصل. كثير سهل انه الواحد يرفع السماعه ويتصل. اذا حاس انه الرساله تبعك ممكن تكون مسرد، ارفع السماعه، ارفعي السماعه اتصلي. دائما يكون واضح الكوميونيكيشن تبعنا، دائما يكون محترم، دائما يكون تايملي. كثير مهم. طبعا لما نتصل على حدا مثلا لو عندك دقيقه، مو والله نتصل على حدا انه انا عندي سؤال. ممكن يكون الشخص عم يعمل بروسيجر، بقول له لا عفوا حكيني بعد شوي. تمام. فكثير مهم لما نكون نتواصل نكون عم نتواصل بشكل واضح، بشكل بروفيشنال كمان. آه، الشيء الثاني هو له علاقه بالديجيتال فوت برنت تبعنا. سوري انا في سلايد راح، او في سلايد شايله انا بالغلط. بس في قصه لها علاقه بهي موضوع الريلايبلتي. في ريزيدنت ب آه، بنيويورك ب 1984. هي الريزيدنت توفت. عفوا مريضة توفت، مو ريزيدنت. مريضة توفت ب 1984. هي المريضة توفت اسمها ليبي زاين. ليش توفت ليبي؟ لأنه كان السيستم وقتها في ساعات دوام طويلة كثير. فكان العالم مثلا تعمل شفت 36 ساعة أو أكثر حتى. فهي الريزيدنت بعد ما ماتت لما عملوا تحقيق بالموضوع شو طلع السبب انه كثير من الريزيدنتس كانوا عم يجهدوا وما عم يقدروا ينتبهوا على شغلات، وما كانوا عم يطلبوا مساعده. مثل ما قال جهاد، اذا عندك سؤال ما تتردد بسؤال، بانك تسال. اذا في شيء ما بتعرفه ما تخترع من عندك، ما تخترع من عندك، اسال عادي. I always tell people there's no bad question. All questions are good questions. كثير مهم هذا الشيء. إذا ما انكم متأكدين اسألوا، هذا جزء من الاحترافية، هذا جزء إنك تكون بروفيشنال. أما تروح تخترع الشغلة من عندك وتعمل شيء ممكن تضر مريض أحيانا. فهي الشغلة يطلع منها، مثلا هي قصة الديزاين طلع منها وقت ساعات دوام العمل. آه شغلة ثانية حنحكي عليها أو حكينا عليها، حنحكي على الديجيتال فوت برنت تبعنا. طبعا أنا ما كثير على السوشيال ميديا مثلا، ولكن في كثير ناس، أغلب الناس حاليا على السوشيال ميديا، حتى كثير عالم هلا على إكس أو تويتر سابقا بيحكوا على الكارير تبعهم وكذا. أهم شيء تذكروا إنه أي شيء بتحطوه على السوشيال ميديا هو permanent and public. ال AMA اللي هي الامريكان ميديكال اسوسيشن في عندها articles على هذا الموضوع. never post anything. ابدا ما نحط اي شيء that could identify a patient. ممكن ما نحط اسم المريض، نقول والله في رجال اجا على الغرفة رقم على المستشفى تبعنا بهاليوم هذا، نكون نحن كشفنا معلومات المريض. او ممكن نقول انه عندنا رجال او بالغرفه 15. هذا طبعا هذا الحكي حتى بالتكست. يعني لما تبعتوا تكست مسج تذكروا انه التكست مسج هو مو مكان للتواصل باسماء المرضى او اشياء. اي شيء ممكن يدل على معلومات المريض ما لازم يكون بالتكست، اي شيء. فدائما انتبهوا نحن عم نتواصل. اذا انتم عندكم بروفيشنال اكونت حاولوا تعملوا بروفيشنال وبيرسونال اكونت. يعني ما نعمل بيرسونال بروفيشنال اكونت يعني اذا نحكي عن مواضيع ما لها علاقه، لانه افترض انه الاشخاص المرضى البروجرامز ممكن يقروا عن يشوفوا الاكونت تبعك. اساسا نحن عندنا بالالجوريثمز حاليا بيشوفوا، بيدوروا على السوشيال ميديا اكونتس تبع العالم، وبشوف اذا هذا الشخص بروفيشنال او ما بروفيشنال، او بيقعد بيحط شغلات ما لها علاقه بالبروفيشن تبعنا. آه احد اسهل الطرق حاليا، احد اسهل الطرق لحتى تدمر حياه المهنيه لشخص هو السوشيال ميديا. يعني اسهل طريقه انك تدمر حياتك المهنيه هو عن طريق السوشيال ميديا. البوست اللي ممكن نحطه ممكن تخرب لنا الكارير تبعنا كله، ممكن الناس ما تعود توثق فيك، ممكن في كتير قصص للاسف هلا سمعناها خلال اخر فتره، خاصه خلال اخر سنتين، على ناس قلعت من شغله على بوست هن حاطينها. لذلك separate your professional account from your personal account. الشيء المهم اللي انا يعني في قانون حطوه ببالكم، او انا بقوله للريزنس اذا حدا صار معه مشكله: if you would not say it on rounds، الشغله انت ما بتقولوها بالراوند ما تنشروها، خاصه على البروفيشنال اكونت تبعكم. هلا البيرسونال اكونت اذا عندكم عالم من الشغل عليه وهن ما لهم close friends، this is not a place to place personal شغلات اللي علاقه بالشغل. اي شيء له علاقه بالشغل should not be posted on social media. You want to use social media, use it to for branding، اعملوا براندنج لحالكم او كذا. بس كثير كثير مهم انه ننتبه ما ندخل مواضيع المرضى على يعني ما هي مثال هون، ما تقول والله اجانك 82 year old refusing treatment some people ما بعرف tough night. مثال ثاني انه tough night in the ED grateful for my team lessons and communication we keep learning. طبعا كثير تشيزي هذا الثاني، بس هذا يعني هي الطريقه انه ما لازم نحكي اي شيء ممكن يصير. ممكن إنه حدا يحكي شيء يسيء للمستشفى تبعه او للتنك تبعه، لذلك كثير لازم ننتبه. شيء ثاني حكاه جهاد ايضا هو to speak up. عادي نختلف مع الناس، كثير عادي نختلف مع الناس. انا بختلف مع الناس كل يوم. انا حتى لما بنعمل راوندز قلنا للريزيدنتس please disagree with me. I want you to disagree with me. انا لحتى اعلمهم بدي I need them to disagree with me. بس when you disagree with people، خاصة مثلا مع النيرسز أو كذا، في طرق مختلفة. في واحدة منها اسمها الاس بي اي. اس بي اي you describe the situation، بتقول شو صار، بعدين بتقول شو الشغله اللي صارت، او بتحكي على السيتويشن. مثلا انا بالمريض الفلاني اليوم الصبح بيهيفير شو صار. مثلا كان الاي في لاين تبعه كلاغد كل الوقت، كان الاي في لاين مسكر كل الوقت وما عرفنا نشغله، ولذلك المريض تاخر انه ياخذ البلود ترانسفيوجن. ممكن تصلحيه مثلا، تساعدينا نصلحه او كذا. فدائما نحكي بشكل اوبجكتيف، نستخدم هي احد الطرق، مثلا هي الاس بي اي. نفرض احيانا ممكن الممرض او الممرضه يتصلوا فينا يقولوا لنا اوف انت حطيت اوردر وعملت هيك بدون ما تحكي معي، او انت عملت شيء. ما ناخذ اي شيء بيرسونال، دائما نحطه قلبوا كل شيء من بيرسونال لبروفيشنال. دائما نوجه الموضوع باتجاه المريض. مثلا ممكن عفوا صح البلان تغيرت بالراوند، غيرت او الممرضه قالت لك المريض قال لي شيء، انه مثلا هون الممرضه قالت لك انه المريض عم يقول لي شيء ثاني وانت ما قلت لي اياه، فانه والله البلان تغيرت بعد ما حكينا بالراوندز. انا اسف المره الجايه حاحكي معاكي مثلا بكير، اول ما نغير البلان بخبرك مشان تعرفي انت وتخبري المريض مثلا. طبعا دائما نعمل فيدباك بشكل كونستركتيف بشكل بناء. اذا في شيء اختلاف ما نصعد مع الشخص مباشره، نطلع مع الشخص السينيور اللي عندنا. مثلا اختلفتوا مع النيرس، احكوا مع السينيور ريزدنت تبعكم، اشرحوا له شو صار ونشوف كيف بيقدر يساعدكم. ما مشي الحال يو كان ريبورت للتشيف ريزدنت، ما مشي الحال للبروجرام دايركتور. دائما في باثويز، نصعد بالشكل الصحيح وما نصعد بشكل شخصي، ما في شيء اي شيء ابدا شخصي. آه 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 اذا مره ثانيه اذا النيرس حكت معاكم عم تسالكم على اوردر، ما تقولوا انت شو فهمك او انت شو فهمك شو عرفك، بالعكس اسالوا، ممكن يكون عنده كلام صح. انا اكثر الناس تعلمت منهم احيانا بقول النيرسز تبع الاي سي يو. لما كنت الاي سي يو ما كنت بعرف شيء بالعنايه المركزه، اكثر ناس تعلمت. انا كان عندي اول ما بلشت يعني اس فاكولتي بجي اي كان عندنا ممرضه خبيره كثير بالمناظير. لما اكون انا وياها بسالها بقول لها شو رايك، شو نعمل، شو بتقترحي نعمل، هاي انه عندي ليجن معين او كذا، شو رايك، شفتي حدا عمل شيء ثاني من قبل، do you have any experience with this. عادي بالعكس احنا كلياتنا تيم ورك، what matters ultimately is the patient. طبعا كلياتنا بنحكي مع الاشخاص بشكل محترم. لما ما بتحترموا النيرسز، بالذات النيرسز شيء خطير كثير، لما ما بتحترموا النيرسز وانبنى عنكم فكره سيئه راحت عليكم. النيرسز حيكونوا هن يعني الكابوس تبعكم، ممكن يعملوا اسوء، ممكن يخلوا حياتكم miserable على الاخر. فانتبهوا كثير، ديروا بالكم على النيرسز دائما. بس قصة على هالموضوع، انه في دكتور بالزمانات كان عم يحكي عن موضوع انه كيف لازم نغسل ايدينا وما بعرف شو، بس هذا الزلمه صار يقلل الادب عن الدكاتره، انه انتم وسخين وانتم ما بتنظفوا ايديكم وانتم. وبالاخر ما حدا سمعه، الا بالاخر بين بالدراسات انه العمل صح اللي عم يحكيه صح. فلذلك ممكن تكون انت عم تعمل احسن شيء، ممكن تكون احسن دكتور بالعالم، ممكن تجاوب احسن اصعب مريض، ولكن اذا ما حليتوا المشكله اذا ما حكيتوا بشكل بروفيشنال ما حدا حيسمعكم. آم، تذكروا دائما انه نحن بالبيت سايد هي نيوترال جراوند. يعني أنا عم نحكي سامز هن منظمه الموضوع. سامز هو اكبر مثال على النيوترال جراوند. اذا في مريض ما منطلع والله انت من وين وشو اسمك وشو وجهتك السياسيه وكذا، your feelings and your story are legitimate، بس بالكلينيكال سبيس it doesn't matter. هذا مو المحل اللي نحن حنتناقش فيه مع الناس وانت ليش هيك ولا. نحن بنعالج الكل مثل بعضه، لازم we have to keep the medical neutrality all the time. لازم نكون دائما نحن يعني حياديين بشكل طبي. شغلة إلها علاقة بالبوليتكس. حاليا الأجواء السياسية مشحونة كثير، كلياتنا بنعرف. كثير منا ممكن يكون على فيزا أو حيكون على فيزا. أنا ماني محامي ولا شيء، وهي ما ليجل أدفايس. بدكم تسألوا ليجل أدفايس اسألوا جي ام اي، أو إذا في لوير عندكم. بس إذا مريض، واللي هو حيصير معاكم، ممكن مريض يسألكم أو اسمك أحمد أو اسمك كذا، أنت من وين، أنت من سوريا. ممكن يفتح موضوع مثلا له علاقة بالمشاكل بالشرق الأوسط أو بسوريا أو بالحرب، أو إلى يقول والله أنتم مثلا إرهابيين، أو ممكن كثير شغلات. redirect this، ما بهم. ممكن يكون حدا كان بحرب هنيك واجى لعنا عم يعالجه، ما بهم. redirect this discussion always، لهم شكرا يعني acknowledge the question تبعهم و redirect it. مثلا I keep my focus on your health، خلينا نحكي نحن عنا appointment هلا، خلينا نحكي عن موضوع الهيلث تبعكم. this applies to all politics. فتذكروا انه الفيلينجز تبعيتنا ممكن إن هذا الموضوع يضايقنا اللي انحكى، ممكن كذا، بس خلوا الفيلينجز تبعنا على جنب. اذا بدنا نحكي بالفيلينجز تبعنا نحكي مع رفقاتنا، نحكي مع الكوميونتي تبعنا، ما بالضروره نجيبه على الشغل للفيلينجز تبعنا. آه شيء أخير، كلياتنا حنغلط، كلياتنا حنغلط. ممكن يوم ما نعمل فولو اب، ممكن يوم ما نعمل ما نكون ما نرسبوند، ممكن ما نعمل شيء. أهم شيء we own it. تذكروا إنه الاي سي جي ام اي عندهم بروسيس، هي البروسيس إنه لازم تكون فير. هي فير، في لازم يصير مثلا أحيانا صار مشكلة كبيرة بصير تحقيق انت معلوماتك محميه، ما حدا بيعرف معلوماتك محميه. اوبس ما بعرف شو عملت، سوري. اوبس. معلوماتكم محمية، ما حدا بيحكي عنها. انت الكل حيحترمكم، ما حدا يحكي معكم بشكل قليل أدب. فتذكروا انه هذا الشيء يعني محمي دائما. الشيء الثاني اون ذا بروبلم. انا عملت مشكلة انه صح والله انا عملت هالشغلة، خبر التيم انه انا خبر التاني والله انا I didn't follow up on this. This is what I did to fix it مثلا، او I did this mistake I'm gonna fix it now مثلا. update the plan accordingly. تمام. كونوا honest، كونوا صريحين، أو أنا غلطت. كونوا honest مع حالنا ومع غيرنا حتى، صح؟ إنه I made this mistake. وعادي. وعلى فكرة الريبورتينج سيستم هون دائما نقول report all the errors that you see reported. ما في حتى عملوا شيء بسموه M&M conference اللي هو mortality and morbidity conferences. هذا بنناقش فيه الأخطاء الطبية اللي صارت وكيف نتجنبها. الأخطاء الطبية اللي بتصير تتعالج بشكل عن طريق الأنظمة، نغير السيستم الطبي لنمنعها. فلذلك هي حتصير. فدائما we report the problem and we see how we can fix it. واحيانا اذا عم يصير معنا مشكله بشكل متكرر نسال حدا، اذا عندنا منتور نساله انه اوكي how do I do this better، او حتى حدا اعطانا فيدباك اللي اوكي how do you suggest I do this. يعني مثلا احيانا ريزنت عم تاخر وكتير بقول له اوكي plan to come early، تعال بكير، خلينا review the patients earlier مثلا. او ما اعمل follow up، قول لهم اعملوا check boxes every time you want to review the patients. لما نحكي براونز اعمل check boxes، make sure that we check all the boxes. لذلك ما تنسوا ممكن نغلط او كلياتنا حنغلط، ريكفري از ايزي. المهم انه نعمل هذا الباترن، انا غلطت بعرف اصلح الغلط. اخر كلمه حقولها وجهاد حكاها اي ثينك، نحن سفراء. يعني انتم كلياتكم سفراء. انتم الشخص حكى على الاخ نعيم، وكيف الاخ نعيم اجى اخوه، اجى مرته، واجى بعدين كلياتهم صاروا تشيف ريزنس. يو ار يعني كلياتكم سفراء هون. انتم امباسادورز. كل مريض انتم بتعالجوه حيحكي عنكم كاطباء سوريين. كل شخص تعامل معه حيحكي عنكم كاشخاص كاطباء سوريين. عملتوا كل الشغل الصعب لتوصلوا لهون. تاكدوا انكم تكونوا سفراء ممثلين مو بس لحالكم، لبيتكم، للكالتشر تبعكم. مره ثانيه انتم عملتوا كثير لهلا. ما تخلوا حدا ياخذ الفرحه منكم. بس تذكروا we stay professional. This is all about work now. يعطيكم العافيه.
شكرا جزيلا أسامة، إن شاء الله يعني presentation رائع. شكرا جزيلا، ممتاز. We are running out of time، بس ناخذنا يعني 2-3 questions quickly. في سؤال دكتور عمر حطه على الشات، ممكن نسأل دكتورة شمس if she's available to answer. His question is, how should we handle the handover?
Thank you, Dr. Umar, for the question. In terms of the handover, I think try to be as succinct as possible. The night team that's coming is going to listen to handouts about up to 70 patients, so they don't really have the time to hear the full story about the patient. So just give them a short story about what are they here for, how sick is the patient, and always have contingency plans for the night. For example, if the patient goes hypotensive, give them this amount of fluids, for example. Check, this is their EF. If the patient becomes hypoxic, do a chest x-ray, do ABGs, and so on. So always have contingency planning, and make sure that you you place PRN order medications for all your patients that they might need, like pain medication, sleep medication, nausea, so that it wouldn't really affect the night team's workflow. I can later on send you a template for the handout that you can use for all your patients. I think that would be helpful. So in summary, just be succinct, contingency plans, and make sure you have your PRNs in place.
Thank you. Yeah, agreed. You will make the night person's life easy if you tell them what to do in cases of, because they don't know the patient. So that's the key. إذا ما في حدا عنده سؤال، أنا عندي سؤال لأسامة. There is a fine line between the patient is there and they're struggling and being compassionate with them, and then patient is truly rude to you, or let's say عنصري or any kind of these bad experiences that you may get, and many of us have went through. What's your advice يعني incoming residents? How should I handle this if I am in such a situation?
مظبوط كلامك كثير كثير مهم. سؤال عن جد حلو كثير. أهم شيء أنا بس أحاول، أهم شيء ما نغلط باتجاه المريض. يعني هي أول شغلة. يعني المريض ممكن يغلط. لما أنا بغلط اتجاه المريض، يعني نفرض مريض قلل أدب معي، إذا أنا قللت أدب مع المريض صرت أنا جزء من المشكلة. يعني if they do anything wrong toward you, do not do anything wrong toward them. هذا جزء من professionalism صح. we maintain الكاركتر تبعنا. واحد. اثنين، we try to de-escalate. لو أنا مثلا عادة من لو أنا I feel like you're frustrated. هل في شيء أنا عملته، أو هل في شيء صاير ممكن أفهم أنا ممكن أساعدك فيه. إذا صعد المريض أكثر فينا أحيانا نقول أوكي I'm gonna come back later مثلا. وممكن نحكي مع السينيور ريزيدنتس تبعنا ونقول له هذا المريض هيك هيك صار معي لحتى يصير. هلا لما يكون الاند اوف ذا لاين، مثلا انا احيانا بفوت على مريض انا اتندنج بيقول لي انه انا ما بدي احكي هلا، ما بعرف شو. لا اوكي طيب ماشي برجع بعدين. عرفت؟ I'm not gonna make a big deal of this. عرفت؟ أنا ممكن إنه لا أنا بدي أشوفه، بدي أخلص راوندز وعندي عيادة وكذا. I'm not gonna make a deal of this. خلاص أوكي ما بدك يعني أشوفك هلا، أنا برجع بعدين. easy. تمام؟ بس don't escalate. أهم شيء do not escalate. ما حدا يعمل escalation. ما نصعد، لأنه بس صعدنا صرنا جزء من الخطأ. هي أهم شغلة. أنا I've been guilty once إني صعدت مع مريض. يعني somebody يعني صعد كثير، يعني I ended escalating و I regret this all this time. يعني قصة ل5 سنين I feel bad about it. طبعا ما صار شيء كبير من الموضوع ولا شيء. يعني patient قلل الأدب كثير، بس ultimately يعني got fired from practice وكذا. بس أنا يعني إنه I didn't need to do this. خلاص إن الأدب كثير أنا انتهت. أساسا إذا مريض الأدب they're breaking the trust relationship between us and them صح. And when they break the trust you cannot treat them anymore. خلاص. If they don't trust me I should not treat them. Nobody can force me to treat a patient that doesn't trust me صح. فكتير مهم. أهم شيء ما نصعد. Never escalate. That's the rule.
الله يعطيك العافية. طيب, we're gonna move on to the second session. Anyone has a very pressing question before we move on? One last question, if any. Unmute and go ahead. 3, 2, 1. All right, perfect.
How can I
Thank you.
get into the record?
Go ahead.
Hi, Dr. Chaar. Thank you for
Hold on.
that. So, can you please tell me how you will share this session with us? I came a little bit late.
So we are recording. Most likely we'll end up uploading this to our YouTube channel. So stay tuned.
Thanks a lot.
Yeah. But I'm gonna hand. Thank you so much for our speaker, Dr. Chams, Dr. Jihad, and Dr. Osama. We learned so much. And I'm gonna hand it over to Dr. Mohammed Sayed for the second session.
Assalamu alaikum. اسمي محمد السيد. I'm one of the SAMS board members, and I work also with the education committee for the last 11 years. Thank you so much for having me here today. I'll be very quick. I'm here to moderate for the second session for day 1. And in this session, we're going to have 3 lectures, inshallah. We're going to start with the pre-rounding and rounds workflow with Dr. Ahmad Nawlo. And then the second, we're going to talk about the workflow efficiency and time management by Dr. Abdelkader Chaar. And then we're going to end with best practices in documentation with Dr. Majdi Salahie. So we're going to start with the first session. And the first session will be by Dr. Ahmad Nawlo. Ahmad, I know him very well since he was a medical student. He was a very bright student, and mashallah, he succeeded in getting into residency into the US. We worked on research, and mashallah, he did excellent work during that time. And I'm sure that he will continue to do that, inshallah, in the future. Of course, he's a graduate of Halab from 2022, and he did 1 year of residency at the Aleppo University Hospital. And then he came to Boston for a postdoctoral research fellow at Harvard, and he spent there 2 years. And now he's going to be a second-year internal medicine resident at MedStar Georgetown University, and he's interested in going into cardiology. So Ahmed, you can start your presentation.
Assalamu alaikum, everyone. رح أحاول أحكي بالعربي. إذا الكل هون بيحكي عربي. الله يعطيكم العافية جميعا. Again, it's truly a pleasure to be here. استفدت كثير من قبل من البوت كامبس تبع سامز، وحسيت إنه it's the time to give back. اللي رح أحكي اليوم بشكل عام عن الورك فلو، الاكسبكتيشنز تبع الورك فلو ك first year resident or as an intern. فرح ركز أكثر شيء على البري راوند. قبل ما أبلش أحكي بالموضوع هاد، في شيء لازم تعرفوه، إنه الاكسبيرينس بتختلف كتير إذا أنت عامل ريزيدنسي من قبل. الاكسبيرينس بتختلف كتير اذا انت عامل electives من قبل باليو اس، وبتختلف اكثر على حسب يعني وين عملت وشو عملت من قبل. فالورك فلو بدي احكيه هلا، بصراحه هو نوعا ما يعني في كثير اختلافات ممكن بين البروجرامز، ولكن الورك فلو نوعا ما باليو اس هيلث كير سيستم تقريبا نفسه. فبالنسبه للموضوع اللي رح احكيه، اول شيء انه انت البري راوند اللي بتشتغل عليه، او when you show up to work، لازم تعرف انه دائما الفيرست امبريشن ماتر. انا رح احكي هلا من وجهة نظر يعني اول شهرين بالريزيدنسي. ف you should know like first impression matter. فالشيء اللي رح تعمله انت اول شهر او شهرين هذا نوعا ما حيضل معك طول الوقت. رح ينعرف من البداية إذا أنت you give reliable information. رح ينعرف من البداية إذا أنت ممكن الناس trust your opinion or trust your report. أنا بتذكر أول ما بلشنا ريزيدنسي أكثر شغلة ركز عليها البروجرام دايركتور، قال إنه كبداية أول كم شهر أنت كإنترن في لك أدوار كتير عم تشتغل كتير، ولكن one most important job that you should not fail is to be a good reporter. Good reporter mean you have all the information you need and you give the accurate summarized point about your patient. فأنا رح أحكي هلا ممكن إذا ما عندك experience باليو اس هيلث كير سيستم ممكن بعض المصطلحات تبين غريبة، لكن شباب الله يعطيهم العافية يعني وضحوا كتير قصص. بنصح بخلال هي الجلسة إنه إذا حدا حب ياخذ مثلا نوت أو شيء معين، بحيث إنه وقت رح نبلش بالريزدنسي بعد كم أسبوع من هلا يكون عندنا فكرة عامة كيف الورك فلو عم يصير. فرح بلش انه شو هي الغايه من البري راوندينج. بصراحه وقت كنت بسوريا يعني البري راوندينج ممكن يصير ممكن ما يصير، ولكن ما له يعني شغله اوفيشال. اما هون البري راوندينج is like one of the most essential part of rounding on patient. آه، المعنى العام للبري راوندينج هون انه انت لازم تعرف البيشنت، يعني كل التفاصيل تبع البيشنت، بحيث يكون عندك كل الداتا تبعهم. وقت يبلش الراوندز مع الاتندنجز مع التيم، يكون عندك انت نوعا ما فكره عن البلان والاسسمنت based on the data that you gathered during the pre-round. ف رح امشي انا بالورك فلو اللي نوعا ما يعني كل حدا رح يشتغل على developing a certain workflow that works like well for certain person. ولكن workflow نوعا ما إذا كنا عم نحكي على the most important thing that you should not miss هو نفسه تقريبا. أول شغلة بنصح فيها مثل ما الكل حكى إنه arrive early. أنا أذكر يعني، وهذا الكلام أنا أخذته نصيحة من أشخاص، إنه أول شهر أو شهرين حسب يعني أنت كيف بتشوف حالك، ولكن arriving early is very very important. And by early means maybe 1 hour, maybe 1 hour and a half. Sometimes you will need 2 hours. Maybe راح تشوفوا إنه too much، لأنه إذا sign out مع النايت تيم او الهاند اوفر ببلش يعني تقريبا بالستة ونص او 7، فانت عم تحكي عن توصل على المشفى الساعه 5 او 5 ونص. 5 ونص معناتها عم تحكي انك حتفيق الساعه 4 4 ونص. ممكن بحكي على ديتيلز صغيره، ولكن هذا الشيء كثير مهم خاصه باول شهر او شهرين. انا بلشت السنه بسيرفيس كانت شوي صعبه، هي الاي ام سي. فنوعا ما كان موضوع انه توصل مبكر شيء جدا جدا مهم. ف arriving before the team is mandatory. لانه حتوصل اول شغله لازم تعملها اول ما توصل هي تفتح الشارت تبع البيشنت. You will usually have between 6, 7, 8 patient depends on the program. Usually the cap is between 7 to 8 patient. My program cap is like 7 patients. So if you are capped, it means that you have all the spots filled. You will have 7 patients. So number one, you have to review the vitals. Go to the vitals because the night team is busy now and they're gonna like have their own stuff. فانت بتروح مباشرة على الفيتالز بتشوف طلع اذا مريضك صار في عنده اي تاكيكارديا ابيسودز مثلا كانت documented، كان في عنده اي hypotensive episodes. حاول انت تاخذ فكرة عن الفيتالز overnight. It's gonna be like 12-hour kind of picture. So it's not going to take more than like 30 seconds to look over. بعدها اللي بنصح فيه دائما انه check the notes if there's any overnight event. For example, you are in the ICU and you arrive, the night team are busy and you're just starting pre-charting your patient. Check if there's any overnight note, like maybe a patient coded overnight, maybe a patient went into AFib with RVR. So هذا الشيء بيعطيك فكرة نوعا ما وقت رح يجي النايت تيم ويبلش يعطيك الاوفرنايت event from their perspective. You at least have some questions in mind or at least have some understanding about your patient. Now you gathered the vitals, you gathered kind of like if there's any labs, you look any overnight events or any overnight note and make sure to look also nurse's note. You have all the pictures, all what you need to listen to the night team, get the sign out, you are ready to start your day. So this is kind of like, I would say this is what I find very efficient so far in my intern year. So حاليا انت اخذت الساين اوت. You're gonna start the actual pre-rounding on your patient. You're gonna go and see your patient. فانت في شغلتين انا بنصح فيهم دائما. طبعا يعني اكيد معنا بالبانل هون attendings اكيد يعني اذا في اي فيدباك على الخطوات هي. انا دائما بشوف اهم شغلتين انه قبل ما تروح تشوف المريض تبعك قبل ما تدخل على الغرفه تبعه. check two things. Number one, check with the nurse. يمكن أكثر شغلة انحكت بخلال السيشن اليوم هو إن النيرسز خاصة يعني باليو اس they are really involved in patient care. يعني أنا كنت لما كنا بسوريا موضوع انك انت غالبا تشوف المريض اكثر من اي حدا تاني. هون لا، بشوف انه النيرسز sometimes they know the patient more than you know. And this shouldn't be the case moving forward. Like يعني بعد كم يوم من الروتيشن تبعك لازم تصير تعرف المرضى أكثر من أي حدا تاني، ولكن في البدايات لأنه هن دائما like first responders if I should say. فcheck with the nurse. اسأل في شيء مثلا معين حابة تخبريني إياه، في شيء لازم أعرفه. هذا الشيء كتير مهم. أول شيء أنت عم تبني علاقة مع النيرسز كتير منيحة، هذا الشيء رح يساعدك. مثل ما قال دكتور أسامة إنه النيرس يعني صراحة هي المسؤولة نوعا ما إنه تعمل حياتك منيحة. يعني it will make your life better or worse in the hospital. She can call you with anything and you should respond. Like this is your responsibility. فأنت بلش مثلا في أي شيء بدك تخبريني إياه، في شيء لازم أعرفه. هذا السؤال كتير. Is there anything I should know about the patient overnight؟ راح تقول لك والله هيك صار أو ما صار شيء أو patient was stable, patient was asleep. Now number two, and I think يعني أنا بتذكر إنه كتير طول معي الموضوع لبين ما تعودت على الفكرة هاي إنه check telemetry. يمكن هي كتير practical point. لذلك عم بقول يعني مجرد ما إن شاء الله تبلشوا بالريزيدنسي حتشوفوا بعض النقاط هاي إنه أو فعلا لازم نعمل هاي القصة. التليمتري مثل ما بنعرف هو انت عم تشوف الهارت ريت، عم تشوف اي ايفنت كاردياك ايفنت from like from cardiac standpoint. اي شيء حصل خلال يعني الفتره الموجود فيها المريض. If you keep tracking every day you will have just to check like the last 12 or 24 hours. ليش؟ لأنه التليمتري هي صراحة كتير يعني it's safety events. التليمتري مجرد ما شال عنه المريض there's no documentations. But if the patient went like a patient with no AFib مثلا وهو admitted for stroke تمام و you put them on telemetry for 48 hours and they have some AFib paroxysmal AFib فأنت هون بهي الحالة لازم تعرف إنه هذا المريض صار عنده هذا الشيء وإذا ما شيكت التليمتري لأن البروكسيسمال AFib ما راح يكون موجود دائما فهي كثير يمكن دخلت أنا براكتيكال بوينت بس بحسها جدا جدا مهمه وصار عندنا كثير سيفتي ايفنت يعني سمعت بسيفتي ايفنت من وراء انه ننسى to check telemetry. So after you check telemetry now you have يعني 100% من اي معلومات من اي معلومات صارت على المريض. تدخل انت على غرفه المريض عارفان وين تسال وشو تسال وحتاخذ منك فتره بسيطه جدا جوا الغرفه لانه في عندك انت 7 patient round and then you will have to prepare for the round. فلما بتدخل انت عند المريض انا بشوف انه يعني start your question like start your round او يعني الفيزيت تبعك للمريض بسؤال بسيط جدا يعني اساله كيف نام بالليل اساله يعني اذا كان let's say he was admitted for chest pain مثلا تمام there's concern for like acute coronary syndrome فأنت بس فيك تسأل بكل بساطة إنه مثلا أخي are you feeling better or worse is your chest pain getting better or worse هذا الشيء رح يساعدك develop like more accurate differential هذا الشيء رح يساعدك أكثر كمان تعرف يعني كيف to report to the whole team. الشغلة الثانية targeted questions أنت هلا عرفت مثلا لنفترض شفت انت overnight the patient has some hypotensive episodes فانت بتعرف انه مثلا هذا الشيء صار حوالي الساعه 4 الصبح او 3 الصبح ففيك تسال انه خلال هالفتره شو كان المريض عم يعمل. انت شفت مثلا some event on the telly مثلا ممكن تكون المريض كان عم يتحرك ممكن كان some artifact فهذا الشيء كثير بيساعدك انه targeted question you don't have to go like for a full history at that time. خلصت انت مريضك مثلا admitted for like shortness of breath ruling out مثلا PE فبهي الحالة أنت عندك فحصك pertinent يعني you don't have to go full exam from head to toe. Full exam like I would say from my experience يعني بينعمل وقت الادميشنز او في حال صار في تغيير كبير بالكورس تبع المريض لكن انت بري راوند pertinent exam ما لازم يطول هي القصه كلها ما لازم يطول اكثر من 5 minutes per each patient it depends on the acuity of the patient. Now you have overnight event you have all the report all the data you saw your patients you examine them now you're ready to present them حسب يعني كل ورك فلو وحسب الليفل اوف كير ذات يو وركينج يعني ان انا هون عم بحكي غالبا يعني الحكي هذا اغلبه بيمشي مع الاي ام سي والفلورز الاي سي يو شوي ديفرنت لانه يعني مثل ما حكوا زملائنا انه الليفل اوف كير يعني بيكون مور كايند اوف اسكيليتنج ليفل اوف كير في تشينجز لايك بتصير بسرعه كثير كبيره فهذا الشيء بيمشي اغلبه مع الاي ام سي والفلورز اللي هو تقريبا I would say 70 to like 80% of your service will be يعني as an IMC or floors. You're done. هذا الشيء اللي بصراحة هي من أهم الشغلات اللي بحس لو متدرب عليها كان my life would be much easier. اللي هو الفورمات تبع البرزنتيشن. أنا بكون صريح أنا وقت عملت روتيشنز هون باليو اس you will present one or two patient مثلا sometimes you don't present you're just shadowing فأنت you're not really involved in the يعني taking care of your patient فيعني whatever you present they will take it okay. انت لما بتكون ريزيدنت بصراحه وخاصه كانترن فانت اكثر حدا بتعرف المريض وانت اكثر حدا الداتا اللي رح تحكيها هي اللي رح gonna be forming the plan for the patient. فالطريقه اللي بتحكي فيها هي طريقه نوعا ما موحده بكل البروجرامز اللي هي طريقه السوب فورمات. SOAP format stands for subjective, objective, assessment and plan. Basically you just start subjectively you start with what the patient report. يعني البيشنت والله قال لك انت لما شفته قال لك والله my chest pain is getting better, my chest pain. You should mention that لانه هذا الشيء مهم لحتى لما تربطه مع الاوبجكتيفز، مع الفيزيكال اكزام تبعك، مع الفيتال ساينس تبعك. تمام، هذا الشيء جدا جدا مهم. الموضوع الثاني لما انت خلصت subjectively you move on to objective. You can say like objectively مثلا vital sign patient is afebrile, heart rate كذا, blood pressure كذا, respiratory, saturating well on room air, nasal cannula, etc. etc. You're just putting data. Then you move on to the lab or like there's يعني مثلا بتذكر انه attending كان يحبوا لا اعمل اللابس قبل الفايتلز او الفايتلز بعد اللاب. هذا الشيء ما كثير هلا مهم. المهم انه تعرف انه بالاوبجكتيف you're mentioning data points from your chart review, from what happened from the labs that you got on the patient. Then you mention your physical exam. والله البيشنت مثلا كان عنده diffuse wheezing in lung exam. هذا الشيء جدا مهم. الشغله بنصحكم فيها بصراحه كانت تصير كثير معي I receive feedback on that. لما بنحكي بالobjective do not try to interpret the result. Okay, so you're mentioning like hemoglobin is 6 down from 9. I think the patient is bleeding. Do not say that here. Of course, the patient bleeding and you think like they're at risk of developing like hemodynamic instability, you should mention that like before even the round starts. I'm بحكي انه بشكل عام patient are stable, but do not try to interpret the objectives while you're يعني doing them. مثل يعني بينقال فرجينا شطارتك بالassessment and plan. بالassessment and plan مثلا عم نحكي عن هذا المريض. بالassessment and plan بتحكي your clinical impression. انت والله patient came in with hemoglobin of 6. تمام. You start stating مثلا first problem is acute anemia. تمام. طيب why? والله الهيموجلوبين طلع 6. طيب what's your differential now? تمام. Your differential, in order to form the differential, we all know how to form the differential based on the objective data that you have, based on the radiological evidence that you have. So you did a CT GI bleed and the patient was not bleeding on the GI bleed. تمام. Okay, I think مثلا GI bleed is low in differential because of this and this and this. هون فيك تحط الانتربريتيشن تبعك. وبدي احكي موضوع مهم جدا بالشهر الاول او الثاني بشغلك كثير بيركزوا على فكره انه your way of thinking. تمام. يعني انت لما you're trying your best وعم تحط انت كل الديفرنشال تبعك وعم تحاول تجيب الداتا اللي يا سبورت يا بتشيل السبورت من ديفرنشال معين. هذا الشيء كثير بيساعد الاتندنج قدامك انه يفهم انه انت زلمه اول شيء عم تفكر. ثاني شغله انه عم تحاول يعني to narrow differential to the based on the data that you have. And based on the assessment, you start developing the plan. Well, the patient now is like hemoglobin 6. I think he will need transfusion. This is like number 1. Number 2, you need to do some more investigation. We're going to consult, I think GI consult is important here for like possible colonoscopy or something like that. أنا بعرف هون في GI attendings هون يعني الموضوع هذا شوي بعرف critical. فهذا هو بالنسبة للبرزنتيشن. الشغلة الأخيرة واللي هي بصراحة أنا عرفتها للأخير ولكن هي ضمن البرزنتيشن لما بنعمل بالسوب فورمات اللي هو شيء اسمه الون لاينر. حقيقة يعني أنت رح تشوف رح يجي الاتندنج he has like 14 15 16 patient. فما حيكون بيعرف كل البيشنت اللي عندك يعني أنا بشوف أكثر حدا بيعرف البيشنت مثل ما قلت هو أنت. يعني كإنترن تعرف البيشنت أكثر من السينيور تبعك وأحيانا كثير أكثر من الاتندنج. الاتندنج حيعرف البيج بيكتشر. patient came in with chest pain. تمام. we're ruling out ACS. That's it. تمام. بس he will not know that the patient is نفترض انه he's taking his medication, he has a stent two months back and he's not on like taking his Plavix or his aspirin etc. فهي التفاصيل كتير مهم انت تعرفها وتحطها بالسمري. فالسمري اللي بصراحة اللي حابب أحكي عنه هو الون لاينر. الون لاينر نوعا ما لما بتبلش أنت البرزنتيشن، هذا المفروض كنت أحكي مع السوب فورمات، بس حبيت أركز أول شيء على السوب فورمات then I move on to the one liner that we always get asked about. الون لاينر اللي نحكيه هو باختصار بجمل بسيطة جدا أنت عم بتحاول تلخص المريض مين هو وشو عم يعمل هون في المشفى. again قلت لك أول كم شهر أنت نوعا ما بدك تكون good or excellent reporter. Excellent reporter means that you know how to summarize and how to put things in context. رح أعطي مثال، يمكن مثال أكثر شيء يوضح. مثلا 45-year-old male with history of hypertension and diabetes came in with chest pain concerning for aortic dissection, for example. تمام. That's like kind of set the stage. Now we're gonna present the SOAP format, how the patient feels today. So an aortic dissection is gonna be like, for example, an ICU patient. I'm just saying an example. How the vitals, when you're gonna mention the vitals, the attention will be paid like from your attending على الفيتالز، على البلود بريشر، هل هو hemodynamically stable or not. لما بتروح على البلان نمبر 1 راح يكون عندك البروبلم نمبر 1 مثلا chest pain concern for كذا. تمام. طبعا يفضل دائما بالبروبلم list تحط diagnosis not only like a complaint. Chest pain is like kind of symptom. ولكن الحين ما بنعرف المريض شو عنده بالضبط. فاللي بدي أقول لك عليه هون إنه لما you're stating your one line you should not go over every single details. يعني for example, I don't care if the patient has gout or not. I don't care if the patient has constipation or not. You shouldn't put in your one-liner when you're introducing your patient to the team, when you're gonna present this patient in the SOAP format, to put the constipation as like a previous medical history. This patient, 45-year-old, has history of constipation, has history of blah blah blah, and came in with chest pain. What chest pain has to do with constipation. تمام. هذا شيء كتير ببين انك اول شيء فهمان شو عم تعمل، ما عم بس عم تعبي فراغات وعم تحاول تشلف الحكي يعني، وبيبين انك عرفان فهمان المريض شو عم يعمل هون. تمام. طبعا قلت لك مره ثانيه اللي عم بحكي انا هون ديتيلز بتختلف من تيم لتيم، بتختلف من مشفى لمشفى، ولكن نوعا ما يعني مثل يعني نوعا ما ستاندرد هو انك تكون تعرف كيف تلخص، تعرف كيف تو سمرايز. عارف انه كلاتنا عندنا attention span كتير بكون short، يعني كتير limited attention span. ف the more you summarize the better you get heard and the better your like word will be like more like trustworthy. هذا الشيء كثير شفته مهم، خاصة هون باليو اس بتشوفوا انه history is very long. يعني you should mention in the admitting note every single detail about the patient. Okay, but when you're gonna present you have to be very specific. هذا كملخص عن البرزنتيشن. lead with one liner. لما حكيت قبل انه نحن بنمشي على السوب فورمات، نحن لما بنمشي على السوب فورمات لازم تبلش انت بون لاينر. well again this is a patient who's 45-year-old, came in with history of this and this and this, came in with this, being managed for this. Okay, so you led with a one liner. Now all the attention is like on you. تمام. لما بتبلش انت بالassessment and plan مثل ما حكيت بتبلش subjectively, objectively, then you form your assessment and plan. Very very important to state why again, يعني why you think this. You shouldn't say like I think this patient has like especially like الأمثلة اللي عم تجي على بالي كلها شغلات أكيوت غالبا بتنعرف خلال كم ساعة، ولكن في كتير patient بيضلوا admitted for like few days and we still don't know what's going on. Show your thinking in the assessment. It's very, very important. لما when you present your plan يعني always say start with this. I think, I believe. هذا الشيء كتير مهم. مثل ما قال الدكتور أسامة إنه نحن بصراحة يمكن هي cultural thing، تعودنا إنه في عنا التواضع هو أحيانا بيكون تو ماتش هون لدرجه انه باليو اس بتنفهم انه انت مثلا ما عندك ثقه او شيء. فلا هون ضروري شوي تورجي انه I think you can say we think like as a team, it's totally fine. بس يعني انت you're presenting a patient for the first time, it's your patient, you admit them, and yeah, it's very important to say like I think this patient need this. Why? Because of this and this and this. Be brief and organized again, and know your numbers. Vitals are important, but especially in the first few months هذا الشيء لاحظته. يعني أنا حاليا مثلا when I'm presenting I can just say vitals are stable, that's it. But the first few months you need to say what stable means, because الاتندنج ما بيعرف إنه أنت إذا والله الفاين عندك ممكن مثلا blood pressure like map of 55 could be fine for you maybe. ف you should state numbers. يمكن حكيت على كتير ديتيلز، بس يعني لما بفكر ببداية الريزيدنسي حسيت هذا الكلام لو كنت بعرفه من قبل كان يعني it would have made life much easier first few months. لهون بكون خلصت البري راوند ورك فلو. إذا حدا عنده أي سؤال أنا موجود، وإيميلي كمان رح أبعته على الشات. بالتوفيق إن شاء الله جميعا. بدي أقوله إنه بصراحة أول يعني مثل ما حكوا دكاترة قبل إنه أول كم شهر كتير حيكونوا صعبات. I would say أول 2 months first 2 months، بس مجرد ما مشينا فيهم تعود على السيستم، تعلمت اليو اس هيلث كير كلتشر، الأمور بتبلش أحلى وأحسن، وبتبلش نوعا ما you should reach to a point where you come to work and you're happy about it. هذا الشيء كثير حيساعدك بالريزدنسي. توفيق إن شاء الله جميعا، ونشوفكم بأحسن أماكن.
الله يعطيك العافية أحمد، شكرا جزيلا لك. we're going to keep questions at the end inshallah, and thank you so much for staying on time. يعني you talked for 30 minutes exactly your time frame. Next we're going to talk about workflow efficiency and time management presented by Dr. Abdelkader Chaar. He's also a graduate of Halab. I feel like this is a Halab session. I'm also a graduate of Halab, so all of three of us so far. So he graduated 2014. He came to the US. He did his internal medicine residency at St. John Hospital in Detroit. And then after residency, he worked as an attending hospitalist at Yale University. And then he moved to Syracuse, New York to start his GI fellowship. And he is still now doing his fellowship. He is the chair of the education committee at SAMS. I've known Abdelkader for many years since we started working in the education committee, and even before that, he's I feel like he's a very persistent person. He dedicates a lot of time working on all the projects at SAMS Education Committee to make it wonderful. And he's the maestro of the web-based interview skills workshop. We're so happy that he's also organizing this session, and also organizing this residency bootcamp with the other organizers. Allah يعطيك العافية Abdelkader. You have I don't know how much time you have. I think you have about 20 minutes. Inshallah, we're going to keep the questions at the end after the last presentation, inshallah.
شكرا محمد. مرحبا جميعا، السلام عليكم. يعني مثل ما حكينا من قبل، ألف مبروك على الماتش. You guys worked very hard to this moment. وإن شاء الله يعني للأعلى والأعلى بإذن الله. الورك فلو efficiency and time management رح نحاول بهال few minutes نعطيكم هيك شوية tips to make your life easier. رح أبلش بدisclaimer صغيرة إنه أنا I'm not an expert by any means بهذا الموضوع and I have my own efficiency problems. بس I've seen a lot over the last 10 years working in this country's medical system, and I have interest in leveraging technology in my daily life. So I hope I'll be able to provide some some helpful information for you guys. I'm going to be mentioning a few apps. هذا مو معناه انه هدول الابس ان كل شيء موجود. رح يكون هدول عباره عن امثله وانتم وظيفتكم هي انه figure out what works best for you. الغايه من الموضوع انه these things exist for your advantage and you can look up different apps that do the same functionality وتستفيدوا منه. I have no financial relationship with any of these companies. طيب, this is my outline. We'll talk very briefly about clinical workflow efficiency. Ahmad, mashallah, covered on this, so there will be some overlap, so I'll skip on these things. Talk about email management, calendars, task management. Very briefly about studying and education. We will have a dedicated lecture for this next week. Finally, the hot topic of the day, which is artificial intelligence, will also show some cool examples. طيب, بالنسبة للراوندز فيعني أحمد ما شاء الله كفى ووفى بالموضوع. البري-charting, it's not only about you being a good resident. Pre-charting early rounds will make your life easier and more efficient down the road toward the end of the day. لما أنتم بتبلشوا يومكم بتعرفوا كل شيء عن المريض, راجعتوا كل شيء بشكل جيد. لما بتعملوا البرزنتيشن you're going to be more comfortable, you're going to be quicker, you're going to be more efficient, you will have a plan in mind. So that's very important. Always have a system. So مثل ما حكى أحمد, حكى على موضوع إنه بتدخلوا بتشوفوا الشارت, بتطلعوا على التريمتري, بتحكوا مع النيرسز. So have a system. When you first start the first couple months, you're getting yourself to know things. After the first few days, just you're doing things repetitively. So figure out the system that works best for you, that will make you cover the most amount of information within the shortest time, and it will become very quickly, it will become a second nature. And then this is different by the setting that you're working on. هلا أغلبنا internal medicine, so that's why we always bring these examples. بس أكيد في ناس من غير specialties, you guys will have your own things. بس مثلا إذا you're on the floor is much different than you're in the ICU. It's much different than if you're in a clinic setting. So learn the surrounding, learn how things work in these settings, and create your own pre-rounding routine. And just follow this and patch it slowly, add few things here and there, observe others, what are they doing, and add to your own, create your own style. Very, very important, as was mentioned already, speaking to staff. Nurses, especially in the ICU, you should definitely speak to every nurse for your patients pre-rounds. You need to speak to them. ICU is very kind of time-sensitive things, so you will learn a lot. They will make your life easier. Not only that, if they need orders, just figure this on early on, and then down the road toward the end of the day, they're not gonna be texting you all the day and get me orders and whatnot. So figure out what they need and do it early and get done with it. Know your attending style. في attendings بدهم just one liner and move on. في attendings they want very detailed presentation. في attendings in between. في attendings after you work them for a few days, they know you, you know them, then you can modify things. So you can talk to the prior residents, talk to your senior resident, how does this attending like to get things done. So it would be important to understand this before you start your rotation. And then orders, we'll talk about some examples related to orders. Electronic health record. EMR أو EHR or electronic medical records is a big thing, especially إذا أنتم جايين من سوريا, you never worked on an EMR. It can be a source of burnout, but at the same time, it can be a source of making your life easy if you know how to leverage it well. There are so many EMRs. The most famous one are Epic and Cerner. CPRS, if you will be working at the VA, you're gonna have the privilege of dealing with CPRS. There are some other outpatient systems. So في كتير أشكال وألوان من EMR. My most experience has been with Epic, so I'll bring some examples. But a lot of these things apply to other systems. So first thing, we talk about templates. So you should have your own templates. Anything that you do on repetitive basis, even if it's a sentence that takes you 30 seconds to write, you can make it a template, or we call that a dot phrase. So this is an example. I use these things on regular basis. So I have dot phrase for different things. I have dot phrase for, let's say, I have a patient coming in with liver cirrhosis. So I have a dot phrase for my recommendations for liver cirrhosis management. And I make sure, I optimize this as I go. I review the guidelines, make sure all my recommendations are up to date. So whenever I see this next patient, instead of writing the note for a long time, within a couple clicks, I have everything in, and then I can modify it slowly. So this is very, very, very important. Most of the teams, when you start, will have a template for HMP for history and physical. They'll have a template for progress note. They'll have a template for clinic notes. So you should use those as part of being part of the team, and they will share those with you. But you should also get into the habit early on in creating your own dot phrases, your own templates. They will save you so much time. And then in Epic, at least, you can look at other people's templates. So if you look at this is my own template, and if I go into let me do this one thing here. Oops. So if I go here, I can type any person's name and look at their template. So if you like something that other people have been doing, the dot phrases, you can basically copy it from them and use it. Personalize your view. You're going to have a lot of things, a lot of complicated stuff in the EMR. So with a few customization, you can customize how things look depending on your style. So, you can, if you're using, let's say, the fever tab, which has all the antibiotics frequently, make sure it shows up on your list. So, and you will learn these things. I'm not going to teach you how to customize your EMR, because it's every EMR is different. But learn that these things exist. So when you start, you will be able to look into these things and figure it out depending on your hospital. Order management. So you can create your own panel of orders. If let's say you're in the ICU and you're doing the exact same orders every single patient for morning orders. So there is a way, instead of me typing 3 different orders every day on each patient, I can create an order set, and with one click, I have my favorite, and then it will do the orders. So that's something that exists and you can do as well. Inbox management, you're going to get so many messages and letters about, this patient has certain results and you need to review them. So be efficient with that and create your own way. There is, if this is something that you just want to follow up on later, there is a way to postpone things, at least in Epic, and you can use the follow up button. So again, these things can be very overwhelming unless you can start early on and learn how to do these things. Good update. Ahmad حكى على assessment and plan. In some instances, you will round over a weekend with a different attending who's covering your team. And then the last thing you now know is, my attending knew all the patients for the whole week. So I have not been presenting every single assessment for every single patient. بس هلا اجى attending جديد, and you have to repeat the whole story for them. So when you are updating your note every day with an updated assessment, very briefly, so patient was admitted with pneumonia, and then you added the one-liner. Okay, patient is now day 3 of antibiotics, doing well on room air or weaning off oxygen. So you will have your own small presentation in your note whenever you have to present this for the next attending. So that can save you a lot of time. Use dictation. So most hospitals will have dictation services such as Dragon, PowerChart, and basically it's a mic attached to the computer or on your phone app that you can link to your health record, and you can dictate and you can write your note. Basically, this is so and so 30 years old male with past medical history, whatever you want to write, or you can dictate your assessment plan. We're not used to this من سوريا مثلا, get to learn this early on, and it will the system is smart, and it will learn your accent, your style with time, and you will have you will save a lot of time by using this. So get to know this. Nowadays there are AI scribes. Basically, you put an app on your phone, and you will have the app listen to your conversation with the patient, and it will generate a whole note for you. This will save you a ton of time, especially in clinic. But be careful, do not use this on your own without making sure this is something approved by your institution. You could get into big trouble and HIPAA issues. لأن الموضوع البيشنت برايفسي كتير أمر يعني strict بهالبلد. وبعض apps are not HIPAA compliant, they're not approved. So you need to make sure if your hospitals offer this is great, use it and learn how to optimize it. This is the easiest and quickest way to write notes. I have not used it myself because my hospital is still experimenting it, so they did not approve it for everybody. There are only few people who are approved to use it. But if your hospital very clearly say you can use it, and you can use a specific app, they're not going to let you use all the softwares, then go ahead and use it and take advantage of this. Some EMRs have some keyboard shortcuts, so learn about those as well. They will make your life easy. Mobile apps. So have your app تبع السوفتوير تبع EMR على تليفونك. بيساعدكم كتير بالراوندز، أو if you want to look up something quick. على ايامنا كان في عنا اعطونا لابتوبس. Each resident had a laptop, so we used to have laptops with us, and we can go on the floor and look up information as we go. So this will make our life easy. If you have an iPad, you can do the same thing. So figure out a way to leverage technology to your advantage, and then observe others' tricks and efficiency ways. So بالذات بأول شهرين رح تقعدوا كتير مع السينيور residents وراقبوا شو عم بيعملوا، وراقبوا السيتنجز تبع الاي ام ار تبعهم. How did you do this? Teach me how did you do this? So take as much as you can, and then you can develop your own style, and eventually you will teach this to your interns. If you have questions, you don't know how to do something, or you have a customization idea, talk to your IT people. في ناس شغلتهم بالمستشفى هن موظفين لحتى they answer questions for the EMR users. So find where these people sit, or what's their number, and call them, talk to them, and see if they have ideas. There is a track called Smart User Track, be epic. If you're very, very into technology and learning about EMR, you can look this up, and في عندهم more advanced training, and you can create things. You can actually help your department down the road by coming up with efficiency ideas. This is very nice for those who are interested. I've done this, and it made my life much easier because I learned a lot of efficiency tricks. But again, this is a system specific. So حسب ال EMR اللي عندكم, you have to figure out how to get that. Emails. You're going to get bombarded with emails, and you probably have your personal email وفي عندكم الإيميل تبع المشفى. My advice is, if your hospital allows, have one app on your computer and on your phone that is linked to all your emails. So into بapp واحد. هلا مثلا أنا I use Mac. Mac email management system, you can add as many emails as you want to it. So عندي my Gmail, عندي my work email, عندي my SAMS education email, all these things in one place. So it's very easy to move in between. Some hospitals, depending on how the level of security for your IT, they may not allow this. So you can, try to add the email and see. If you get blocked, then you can't do it. Develop some sort of routine for inbox. Inbox fatigue is a real thing, and people can miss things, or they can be late on replying to things. So بالذات your work email is very important to check this on regular basis. So figure out what best works for you. So يعني مثلا I wake up at 5:30 in the morning. I take 10-15 minutes to take a quick look at my emails if there's anything I need to reply quickly, and I clean my email and go on. It doesn't work all the time, but find a routine. You want to do it after your work, you can do that, but find a routine so you don't miss on these things. Most email systems have something called labels, so you can label your email depending on what's going on. This is something related to your research. This is something important related to my studying or my board exam. So you can label them, and I'll show you a very quick example on this. There's something called the zero inbox method. I'm not going to show you how this works, but you can look it up. There are tons of YouTube videos on this, and it is very, very helpful to clean your inbox. If you're not using an email management system, let's say you only have one email or two emails, so it's not worth it for you. You can follow this method. Basically, what's recommended is you have certain labels. So follow up. Let's say action. Let's say read later. And let's say the others are just I don't care. I'm just gonna read the email and move it on. And then basically every single email you go in, and with the keyboard shortcuts you can classify it. So I opened the first one. This is from a YouTube video. So I just screenshotted this. It's not my own email. But anyway, so you classify it. You go in. Okay, I read this. I click one click, and it goes to archive. So I'm done with it. No, this needs a follow up. I go to follow up. This needs an action. It goes to action. And then every single email will be classified in something. And then this way, I will have a completely empty inbox if I achieve that. So learn this trick. It's called the zero inbox method. Calendars, I'm going to show very quick example. So calendar is a very important task to have, because you will be busy. You will have so many things to worry about. So it's good to have a calendar if you don't already, and have a system that you can link to your computer, your phone, and everything. So this is my own personal calendar. So you can have, where was this? Okay. So you basically, I don't know if you guys can see my mouse, but on the left side, you can have as many calendars as you want. So for example, I have a family calendar that I share with my wife, and we add to it our, family stuff. I have this is my personal calendar, has some work related stuff. I'm on call this day, so I don't forget I'm on call on this day. This is my GI lecture, so this repeats weekly. So you can customize it and say, every week on the same time. There is, this is a lecture that I attend every week, so it repeats. So basically, I'll just give you a quick example. So you open this, you type whatever, and then you do this time, and then you can say, hey, I want to repeat this every week, or every month, or not even that. I want to repeat this every, do custom on the second Monday of every month, something like that. So if you have something that is recurrent, you can use it. One other example is you get invitations to certain events. So for example, we send invitations to all the speakers to today's event. So this comes to my inbox, and I approved it, and then now I have all the details here. I have the link that I'm going to be joining through, and then whatever details that the organizers put in. This is another lecture invitation that I got through my email. I can accept, and then it will show up on my email. So you can get all these things. It's very helpful, very efficient. You should definitely have a calendar, because otherwise you can get lost. It's a very, very busy time. So you need to be organized. Your appointments, your lectures, whatever it is. Now, in terms of task management, so task management, there's something called the Eisenhower matrix. So they recommend to split anything you have to do into 4 quadrants. So, urgent and important, not urgent but important. These things you have to do. This is urgent, so you have to really get it done. This is schedule it and, kind of find a plan for it. And then the others, you can either delegate it or delete it. So this concept is very helpful when you have so many things and you can organize your life. There are apps that could do that for you. So I think we're running out of time, but since I have an app called TickTick. So TickTick is, I'm going to share my entire screen here, make it easier. So TickTick, basically, this is my Eisenhower matrix on TickTick. So I have, 4 quadrants and I put my stuff. I can do my research stuff, my work-related things, my family. This is urgent and important. So this is one example of an app. And you can have deadlines. If you go here, you can have, different lists. For example, I get emails and then you can forward from your email to this app and it will be part of your checklist. So this is a list of lectures that I get through my email and I basically forward them to TickTick and will be able to have them on my app, on my phone. So that's one example, but you can look up other examples of task management apps. So this is very helpful, and you can have a checklist, you can have a to-do list. I advise that you try to use one of those things. It will help you a lot. Studying, I'm not going to talk a lot about studying because we're going to have one next week. There are note-taking apps that you can organize your notes in. You can use Apple Notes, you can use, there is Evernote, there is OneNote. There are so many of those, and you can, again, we don't have a lot of time to go through these, but you can look them up. Podcasts on the go, if you're driving to work or if you're commuting to work and you have some time, you can add podcasts. These are a nice and easy way to listen to something. Doesn't have to be work related or study related. You can listen to anything, but there are so many podcasts. It will help you. You can learn about, politics or the culture in this country or whatever you want. There are so many podcasts that you can use and take advantage of AI, but carefully. And we're going to talk about, this is my kind of last thing. And I know I went over, so I'll just show you a very, very quick example. So AI is all over the place now. You can take advantage of this a lot, and you can ask AI stuff and it will generate stuff for you. One of the ways I found very nice and very helpful to do is, Claude is kind of my most recent favorite AI chatbot. So this is a new guideline that came up about hepatic encephalopathy. So I just did this example today just to show you guys. So I uploaded the PDF file and I told Claude, summarize this guideline into a board review style question. Give me 20 questions and give me explanation for them. So basically, you're not telling AI to make up stuff. You're giving them the information and you're just telling them, organize it for me in a certain way. So it gave me 20 questions, and you can answer the question and give you right and wrong. And it's like, war type of thing. And this way, if you like to study this way, you can do it this way. But again, you're providing the information. They're not like regurgitating the stuff for you and you're not sure if it's accurate or not. So that's one way. The other nice way, I also said, provide an outline for presentation. I want to make a presentation about this new guideline, summarizing it. So give me an outline. So it gave me kind of a nice outline, and actually even here, give me more details, outline, and how much time you need for each slide and all these things. So you can look into that. And then the very nice one here, this is surprising. So I said, you know what? I want to study as flashcards. You guys have probably heard of Anki's flashcards. So I said, summarize this guideline as a flashcard thing. So it gave me a link to go to Google, and I got my flashcard thing here. So it's giving me the question, and then I hit space, it gives me the answer. This is all just generated within seconds. And then I move on and it classifies it here. Like here on the top, it tells you this is, this is related to the ammonia, this is inpatient management, this is whatever, and then it gives you the answers. So very neat and nice way. But again, use it carefully because, in this example, I gave it the information, so it will not make up stuff. I provided what I need, and I told them just summarize it for me. So that was a kind of a nice example I wanted to share. And then Open Evidence is the kind of trusted AI chatbot for medical related stuff. And you can use it on the go. It gives you examples with references. So, the other day we had a question, can jaundice cause bradycardia? And I asked Open Evidence, and it gives me a very nice explanation with references. And I went into some of these references and I read about them. Same thing, I had a patient with cisplatin, which is one of the chemotherapies that came in with diarrhea. And I asked Open Evidence, can this cause diarrhea? And it gave me kind of a lot of details in terms of, references and all these things. So you can do so much, but again, use it wisely. Open Evidence is for the most part trusted, but it can have issues in terms of, the website that it's pulling from. So always check the references to be careful. And my last word is universal access is the key here. So whatever you do, make sure it syncs with all your devices, because that's really the key of efficiency. You have to have it on your phone, your computer, whatever. So make sure you have that. And that was it. And I'm sorry I went over.
الله يعطيك العافية عبد القادر شكرا جزيلا. So our next topic, I think we're gonna need to keep going so we can save more time. It will be about the best practices in documentation, and it will be given by Dr. Majdi Salahie, and he's going to be an internal medicine. He is currently an internal medicine resident going into nephrology next year in Texas. So yeah, please go ahead. You have 30 minutes for your presentation, and then after that we're gonna take questions and answers for a few more minutes.
I'm trying to share my presentation. 1 second. Okay. Can you guys see the presentation?
Yes, we can see it. You can, if you wanna make it full screen.
Yeah, 1 second. Is it full screen now?
Not yet, but it's fine. I mean, it's okay.
Okay, that's fine. All right. أول شيء ألف مبروك. The process بالأول بتكون overwhelming. I know it sounds stereotypical, but you learn on the job. بالأول it's going to take time to build your efficiency وكل شيء, but with time you're going to get the hold of things. You're going to get more efficient. Knowledge also comes with time. So you all will be fine. Just like take it easy, take a deep breath. Your seniors are always there. So everything will be okay. All right. So best practices in documentation. I'm an internal medicine resident, an upcoming nephrology fellow. Why do we do documentation? Obviously, patient care. Billing is very important. Billing is variable. It depends on the hospital, depends on the program. Unfortunately, recently there have been issues with insurance and stuff. I'm not going to go into that, but you have to know that part of it might be related to billing, the way that you have to document. That's all you need to know for now. You'll learn about it later if you need to. That's why I don't want to bother you with it. Transition of care to other services is a very important one too. The reason being is, let's say the patient is downgraded from ICU and you're taking over, or he's been upgraded from the floor to the ICU. The team who's going to take over wants to know what was going on with the patient. So a decent note that can tell them the gist of what was happening will be very beneficial and time saving instead of them having like to go through the chart or go back to the admission history and physical and look to find out what's going on with the patient. And always remember the legal part of it. Not documented means did not happen. So you have to be very careful with documentation, especially when you're the primary team, and even if you're on a subspecialty or on a consult service. All right, so the major types of notes that you'll have to do are the admission history and physical, the progress notes, and the discharge summaries. You also have to do consult notes when you're on subspecialties. We're not going to go into those because those depend on the subspecialty and the attending. But the major ones when you're the primary team, whether it's the floor or the ICU, are the admission, the progress, and the discharge. And these, for the most part, follow a certain pattern that you need to be aware of. Okay, so they already told you before, obviously, we have different electronic medical records, Epic, Cerner, Athena, and many others. My current one is Cerner. My fellowship one will be Epic. But basically the gist of the template of the note, it follows the same progress. There's no, there shouldn't be any like major differences in the terms of how the note should be organized, especially when we're talking about admission, progress, and discharge. Okay, so the admission note, the admission history and physical. I didn't want to put screenshots because a lot of people will have Epic. I have screenshots from Cerner, but I'll go through like a simple example and show you how it's supposed to be. The first part of the admission note is the history of presenting illness. Basically, sometimes the chief complaint will auto-populate, like in my Cerner, currently the chief complaint auto-populates, and you start with the history of presenting illness. The history of presenting illness, something you learned in med school. Chief complaint, duration, onset, character, radiation, relieving aggravating factors, progression, the same, whatever mnemonic you want to use, but basically it's the gist of the details of the chief complaint. Sometimes you need to mention in the HPI the pertinent positives or negatives, like if a patient's coming with abdominal pain, you might want to mention like no diarrhea, no constipation, or the pertinent positives and negatives basically. And then you'll have your review of systems. So there's templates for the review of systems. Some people like it very comprehensive, but don't overdo it. Like there are templates that have a lot of stuff that you clearly did not ask about. And that's not going to be like accurate. Like if you're saying no, a billion symptoms that you didn't ask even about half of them, then you're not accurate and you're not being honest with yourself. The physical exam, there's also templates for it. The most important thing in the physical exam is the pertinent findings, the positives, like increased work of breathing, lower extremity edema, crackles, wheezing, tachycardia, skin assessment, a neurologic exam, obviously, if it's like a stroke alert or something. You need to be pretty comprehensive with that. And then the next part is the assessment and plan part. That's from the admission note. In the progress note, for the most part, it follows the SOAP format. I think most of you should be aware that it stands for subjective, objective, assessment, and plan. The discharge note follows the history of this flow. First is the history of presenting illness, then the hospital course, treatments and procedures provided, and then the discharge diagnosis and discharge plan. So these are the major parts of each of the three notes that you'll be dealing with the most on the floor or in the ICU. All right, so let's go with the admission history and physical. As I said, details of the chief complaint, pertinent positives and negatives, recent admissions, especially sometimes they're relevant to the current admission. Medications you can also mention if like new medications have been started and they're relevant to the chief complaint. Like sometimes the patient comes in with altered mental status, and the reason was that they were recently started on gabapentin or Baclofen or something. Your physical exam should have the pertinent findings to the major admission diagnosis. Like let's say it's congestive heart failure, then you're expected to find like lower extremity edema, crackles, the things that you find with heart failure. When you come to the assessment and plan part, so it should be problem by problem. So for example, first problem, let's say, for example, acute hypoxemic respiratory failure, secondary to community-acquired pneumonia. Under that, you justify why you think this is the diagnosis. So you say, for example, patient presented with cough and shortness of breath. CBC, complete blood count, shows elevated white cell count. The chest X-ray shows an opacity or a consolidation. So all of these put together are consistent with a diagnosis of community-acquired pneumonia. So this is how you justify why you think this is the main, like this is the diagnosis or the problem that you're addressing. And then you mention what you're doing to address the problem. So simple example, let's stick with the same one. Community-acquired pneumonia. How do you address this? Blood cultures, sputum cultures, IV antibiotics, and then if they're septic or hypotensive, they might need fluids or whatnot, depending. And then obviously follow CBC, adjust antibiotics based on cultures, assess clinical progression, nasal cannula if they're hypoxic, and whatnot. So basically, how the symptoms and the imaging and the lab findings justify the problem, and then what are you doing to address the problem? And then you have the chronic problems as well. So you might have, like, for example, acute hyponatremia as an acute problem. And then, for example, hypokalemia. These are acute, obviously. These are not going to be chronic problems. The chronic problems are going to be stuff like diabetes, hypertension, dyslipidemia. And then what are you going to do to address these problems? So for diabetes, you're going to put them on insulin. Usually, that's what we do in the hospital. We don't use the oral agents. For hypertension, if the blood pressure is fine or even high, you resume their home antihypertensives. For dyslipidemia, if they're on a statin, you resume it, and so on and so forth for the other chronic problems like hypothyroidism or whatnot. Sometimes there's a chronic problem, but the patient is, for example, let's say septic because of some infection. So under hypertension, might mention, okay, so we're holding blood pressure medication because the patient is septic and the blood pressure is on the lower side or whatnot. Other variables to the admission history and physical depend on the hospital and the program. I'll mention an example of my current program. There's something called that they recently added. It might not be in other hospitals, but I'm not going to bother you with the details of these because you might not need them in your program. But keep in mind, you might have other variables that you add to the admission history and physical based on your hospital or your program. Okay, so that's the admission history and physical. Now we go to the progress note. In the progress note, some people like to put one, as we said, it's subjective, objective assessment and plan. Some people like to put a one-liner in the subjective, as in what is the patient admitted for. Just one-liner, not a complete hospital course. Some people don't do it. I usually like to put it because I don't like, it's easier for me to just look at the subjective. Okay, so this is a gentleman with a history of diabetes and hypertension, presented with diarrhea, admitted with C. diff colitis. Okay, so I know the gist of why the patient is in the hospital, and it saves me time instead of going to a hospital course or a problem list or an assessment template to know what's happening. Now, in the subjective part, after this one-liner that I usually like to put, we're going to talk about the progress of the chief complaint. So, for example, the same example, diarrhea. So the patient, for example, it was a C. diff colitis or some viral gastroenteritis. If he came with 10 bowel movements, so how many bowel movements did he have today? Was it 2? Was it 3? Because that tells me, is he progressing well? Is he responding or is he not? And then this is a tip that I got from one of my seniors. If the things that you need to make sure about is the patient eating and tolerating diet well with no nausea or vomiting. Is he passing urine or urinating? Did he have a bowel movement or not? If no bowel movements, is he at least passing gas? And obviously, like, yes, we're internal medicine, but we should still care about these because sometimes they stay in the hospital constipated for a couple of days and you can't discharge them because they haven't had a bowel movement in like 5 or 6 days. And then fevers, if he had any fevers overnight or in the morning. And then if anything happened overnight, like a blood transfusion or like the patient was agitated and received something for agitation, or he had an episode of hypoxia or whatnot. And then ambulation. Is the patient ambulating? Is he walking with physical therapy? If not, is there a reason he's not walking? These are the main things that need to be in your subjective part. As I mentioned, the most important one is the progress of the chief complaint. So he came in with shortness of breath. Okay, so breathing is improved today, or cough is subsiding. I'm not going to be a perfect or ideal person. I'm going to say it is okay to copy and paste as long as you're updating and changing what's changing from day to day. Like the previous day, the patient got a transfusion. The following day, he didn't get a transfusion. So obviously you need to remove that part, right? The physical exam. He might have had edema and now it's improving with the diuretics. So you need to change the degree of edema on the physical exam. Same thing in the plan. And in the assessment and plan, it's very important to update if you're going to copy and paste. If you copy and paste blindly without carefully reviewing and updating what you're doing, you're going to fall into a lot of mistakes. So let's say he was on IV diuretics and you transition to oral diuretics and you still are copying and pasting blindly, and they're going to check your assessment and plan and see IV diuretics, and then they'll check medications and the patient's on oral diuretics. Why? Because you haven't updated your plan. So I admit that I do copy and paste, but I review 2 or 3 times. I update what needs to be updated. Any changes in the physical exam, any changes in the assessment and plan part. Sometimes there are new problems that you add to the assessment and plan. So please, please, please don't copy and paste blindly and without double checking. And your seniors can help you with that as well. And then in the assessment and plan, you're talking basically about the assessment and the progress of the main problem. So as I mentioned, like simple example, patient is admitted with heart failure exacerbation. So we went him down to room air. He was on nasal cannula. He was on IV diuretics. Since he's breathing more comfortably, he's off oxygen. The chest X-ray is looking better. The edema is subsiding or like getting less in severity. So we're going to transition from IV diuretics to oral diuretics. Same thing, for example, pneumonia. He was on IV antibiotics. The white cell count is back to normal. He's not coughing anymore. He hasn't grown anything in the cultures. So we can transition to oral antibiotics like Augmentin instead of doing like IV Rocephin or azithromycin. So always the main problem that the patient is admitted for, you have to mention how is it progressing. For example, diverticulitis. He came in with abdominal pain. Is his pain better? Did we advance the diet? Is he eating better? Is he tolerating with no pain, no nausea, no vomiting? Same thing with pancreatitis. He came in with like colitis or diarrhea. How is the diarrhea? Is it subsiding? Is it getting worse? Is it the same? That's what you need to mention in the everyday progress note. And then what you're doing to address the problem and the changes. Like if you're transitioning anything to oral, if you have your cultures back and you're de-escalating antibiotics, if you have positive cultures and you need to escalate antibiotics, also you need to mention that. Okay, so sometimes an event can happen later, like later in the afternoon, patient goes into an arrhythmia, like atrial fibrillation with rapid ventricular response, for example. You can add either a separate free text note, or you can addend the main progress note. Either or, I think, should be fine. I would ask the attending. I think some of it might have to do with billing. Sometimes I addend the main note, sometimes I add another free text note. Like, for example, patient was transferred to ICU for whatever reason, for pressors, or he developed shock. And then events that happen during night float, same thing. You either add a free text note, unless it's something like very, very, very minor, like, oh, you gave him Tylenol. But if you're going to be like, you want to be accurate and perfect, document everything, even if it's just Tylenol for a simple hit. I'm just going to very, very briefly talk about ICU because it will take a lot of time if we go deeply into that. ICU go by systems. They don't go by problems. So it's like neuro, cardio, GI, renal, endo, whatnot. Different attendings have different templates and styles, but all of them go by systems. They don't go by problem. And always remember to update the problems. And same goes for the floor as well. So these are the main systems that you need to know in the ICU. I'm just going to mention very, very briefly because it's a whole different scenario in the ICU, so I don't want to go very deep into that. In the neuro system, sedation, pain medications, and the mental status. In the cardio, what type of shock, if he's in shock. Arrhythmias, if he has any arrhythmia, his echo. and pressures, if he's on pressures. Some people like the fluid balance in the cardiology section as well. GI, what is he getting for diet or tube feeds, and then the liver enzymes and the PPI or like GI prophylaxis if he needs it. In the renal section, obviously, how's the kidney function, electrolytes, diuretics, he's on dialysis or not, urine output. And some people like the fluid balance in the renal section. Endocrine, basically sugars, thyroid, or if he's in DKA. These are the main things. Respiratory, if he's intubated on ventilation, then what are the vent settings? If he's on BiPAP, what are the BiPAP settings? What does the X-ray show? What does the ABG show? And the ECMO is a whole different story. Hemonc is just, for the most part, hemoglobin and platelets, unless there's something going on like thrombocytopenia or ITP or acute blood loss anemia. And then infectious diseases, simply what infection are you treating? What are the antibiotics and what go in the cultures? This is just like very briefly. I'm not going to dig deep into that, but you need to know it's system-based, and you'll learn it with time. Now, when it comes to the discharge note, the first part of it is usually the history of presenting illness. What we learned is to use the admission history and physicals, and you mentioned that as per the admitting physician, and you take his history and physical, and then the hospital course. Now, in the hospital course, sometimes it's a very prolonged hospital course. Obviously, you're not going to mention every minor detail that happened every day, because on a daily basis, you're doing many things. Oh, he had a headache, you gave him Tylenol. Oh, the potassium was a bit low, you gave him some potassium. Are you going to mention that in the hospital course? No. You're going to mention the main problem, what you did to address the main problem, any significant imaging or diagnostic findings like an echo or a chest CT or a colonoscopy or whatever it is. And then basically, let's say he was admitted with bacteremia, then you treated him with antibiotics, then you plan to finish the antibiotics in a skilled nursing facility or whatnot. And then like major treatments provided. And if there were newly diagnosed problems during the admission, like sometimes they come in with a different problem, they go into something like atrial fibrillation, they never had it before. So it should be on your problem list, and you should mention that patient had new onset atrial fibrillation during this hospitalization, because that's pertinent to the transition of care when he's going to follow up with the primary care provider and his other subspecialists as outpatient. And then you have the discharge diagnosis and the discharge plan. Discharge plan, most important is, for example, if it's antibiotics, what is the finish date or what is the last date of antibiotics? Because sometimes they finish the antibiotics in a skilled nursing facility or somewhere else. And then obviously medication changes. Like for example, he came in with hyperkalemia. So we decided to suspend the ACE inhibitor, and we're going to continue to hold it on discharge until he sees his nephrologist or his cardiologist. This is important, so whoever is taking over the primary care or the cardiologist or whoever knows why you suspended the ACE inhibitor. Same thing, he came with a massive GI bleed. So we decided to hold the Eliquis until he sees cardiology or whatever, or GI in the outpatient. And then close follow-ups, they need to be mentioned in the discharge plan, like if he was admitted with AKI on CKD and they need to follow the renal function closely. You mentioned, oh, the patient's going to have a follow-up appointment with the nephrologist in 1 to 2 weeks after the discharge. This is what we're doing. This is what he's going to be discharged on. And then with the nephrologist, he's going to have repeat labs to make sure. Some attendings even have you call the primary care doctor to let them know, because sometimes the PCP has a different EMR, and it's not easy for them. I mean, they can obtain records, obviously, but not all systems have like interoperability. So he might not have access if he has a different EMR. So he's going to request the records. So if your discharge summary, the patient can ask for it printed, it's going to help a lot when the PCP or whoever subspecialist he's seeing reads it, because he's going to know the pertinent things that happened during the hospitalization. And then he's going to know if you made any medication changes, why you made them. Always remember, you have to explain why you're doing things. And then these are hospital specific. I'm not going to bother to go into details of them. I'm just going to say that sometimes you can have something like medical necessity, which is basically, why is the patient still in the hospital? Is he on IV antibiotics, and that's why he's still in the hospital? Is he on IV diuretics, and that's why he's still in the hospital? Supportive measures, some people do it. It's a template or a dot phrase. Basically, they use it on the floors, obviously, which basically it has IV fluids, the diet, uh, DVT prophylaxis, and then if there are any consults, and then the discharge planning. Like, am I anticipating this patient is going to go to a nursing facility or he's going to go home with home health? And there's also, depending on the hospital and the program, the anticipated length of stay. I'm not going to bother you with that because you might not have to worry about that depending on your program. I'm just mentioning it because some people might have to deal with it. And I think that's it. I'm sorry if I took too much time or if I talked too fast.
No, that's all good. Yeah, thank you so much for the presentation. الله يعطيك العافية وشكرا جزيلا. I think we finished all three presentations for this session, and I think we can take some questions. I know we are a few minutes late, but I think we can definitely spare maybe 10 to 15 minutes to ask some questions and maybe help you guys to answer them. I just want to make sure that we have all the speakers with us, Ahmad, Abdelkader, and Majdi. So if you guys can stay with us for another 10, 15 minutes. If you guys have any questions, you can definitely either raise your hand or we can. I think raising your hand will be easier, so we can coordinate things easier, and then we'll let you speak. Or if you want to send the question on the chat. In the meantime, one thing I think it's important to talk about, and I want to ask you, the speakers, about it, is how to prioritize your patients. Like especially when you pre-round or when you're around, during that time, like you guys mentioned that you will have like between 7, maybe 10 patients max as an intern. How are you going to prioritize patients? Which patients you're going to see first, which patients you can keep at the end? What is your strategy?
I think I can take this question. Like the idea of reviewing the vitals, overnight events, if there's any notes, just to have an idea about who you should see first. If a patient has like a overnight event for like any certain event that cause hemodynamic instability, that cause like something very significant, that this patient should be seen first. And I think one thing that you should also know, like as an intern, when to call your attending. This is very important. I would say all based on the stability of the patient, and when you're not sure, nobody will blame you if you call. If you're not sure, just call. Do not wait until things get out of control. That would be my sentence of this.
Yeah, great. So we have our first question from Adnan. Please go ahead. You can unmute and
Okay.
yeah.
Hi, everyone. Thank you so much for the amazing presentations. I don't think a place other than SAMS can provide this for the interns and newly coming PGY ones. So my question is, as part of the intern year, it's more about doing the job and doing the work, but it's also important to learn from this year through knowledge and through resources. I know previously it was mainly through UpToDate. We want to look for patients. But since AI is evolving, are there any certain apps like Open Evidence AI or Amboss AI can residents recommend for us? What do they usually use? What are they still using UpToDate like previously? I know UpToDate consumes times while doing the job and doing the consults and the time, but what recommendations can you give? Thank you.
Ahmad or Majdi, do you guys want to answer this since you're doing it, and I can add a brief.
I agree with Dr. Abdelkader when he mentioned open evidence. I think it's like number one evidence or number one to go to resource. Now it's like very fast, very reliable, give you all the resources, And like honestly, I got up-to-date subscription at the beginning of the year. I got Ambus as well, but now that I have open evidence, I'm not using anything else. Like just having this focus on one resource would make life easier for you. That's my own approach. If anyone would like to add something.
I remember my internship. So I used to use pocket medicine. That was the easiest way, and I think the best tool is the tool that you can get the information easier for you. It doesn't matter what it is. It could be open evidence, could be pocket medicine, could be up to date, whatever easier for you, and you can access it very quickly. Especially when you are like rounding or pre-rounding and you need like an answer immediately, I think that's going to be the best tool. If the easiest tool is to open a pocket medicine and then open the page on acute pancreatitis and read like 2-3 lines only, and then get the information you need, then do it. If open evidence, like, and even like you don't even to type, you can actually dictate with open evidence, and that's what I do. I just click dictate. I ask like, okay, I have this patient with hepatitis C. I want to start Epiclusa. Is it okay to start it? Immediately, it will give you an answer. Whatever easier for you, I think that's the best tool. And yeah, I don't know if there are any other new tools, but open evidence is a great one. The problem with open evidence that it happened to me a few days ago. Like I needed some answers while I was rounding, and then it actually said, well, there is an overwhelming demand, and we're sorry for the error. We have to wait, or you have to wait to get an answer. So I think at that time it was like a lot of big load of questions on open evidence. So I wasn't able to get an answer for like the whole day from open evidence. So I have to check with up to date and to check with our other resources. So always keep another tool handy in case open evidence or other tools are not working.
Yeah, agreed. I'm also from the pocket medicine era, so I use pocket medicine a lot. But nowadays, yeah, open evidence is great. My only thing to mention is it's great, as a tool on the go, or even on a daily to daily things or in clinic. But make sure you read something more kind of in details for your your base kind of knowledge, the general knowledge that you're doing. So I usually like to do review articles and more than textbooks. People still tell you have to do textbook, but I'm more of a review article and open evidence with maybe here and there up to date. But on the go, the best tool so far is open evidence. I don't think there is a better one yet.
So we have another question here. As physicians who completed partially residency in Syria before starting residency, do you feel that your previous residency experience was ultimately an advantage or a disadvantage compared to other applicants who came directly from medical school? And what aspects of Syria residency helped you the most? What habits, practices were difficult to unlearn when adapting to the US healthcare system?
I did not do residency in Syria. I think Ahmed did.
يا حسيت السؤال بالنسبة لك رح أحكي هيك لأنه نحن هون كلياتنا سوريين فبنعرف نوعا ما الوضع بسوريا. حقيقة ما شفت أنا من my experience everyone can talk about their own experience من experience تبعي. ما شفت كفائدة علمية حقيقة، لأنه في فرق كبير بين الشيء الموجود هون والشيء الموجود بسوريا. بس you have to take into consideration أنا I did 1 year of surgery in Syria. It wasn't internal medicine. So this is number one. Number two, I think if there's one advantage بصراحة ممكن كمان مرة تانية لأنه هم كلاتنا سوريين فبحكيها. التعب الجسدي اللي بيكون بالريزيدنسي بسوريا يفوق أي تعب جسدي موجود في أي ريزيدنسي بتوقع في أمريكا حقيقة. they do هون 24-hour call مثلا. some hospitals, our hospital do like many 12-hour call. بسوريا كنا نعمل 36 hours 48 hours sometimes. It depends on the department that you work with. فهي الادفانتج انا شفتها كتير منيحة لانه يعني انت you already have like another limit which is not pay attention. Do not mention this يعني do not say oh I used to work 48 hours without like sleeping. This is not a good thing. Like this is not a good thing to mention here. It means that you are working while you're burnt out, which means that patient care is being, you know, not being taken care of very good. القسم الآخر من السؤال بعتقد الهيراركي بسوريا شغلة كتير مقدسة. هذا الشيء مو موجود هون. You have the right to disagree here with your attending, with your seniors, with respectful tone of course. But in Syria it's kind of like كانت خاصة بالأقسام الجراحية كان نوع نسميها نحن عسكرية يعني نفذ ولا تعترض ليست نفذ واعترض ثم اعترض. فبعتقد هي my own experience. Of course like we mentioned that you always should talk about your institutions in a very good manner. دايما احكي انه انا تعلمت انا اشتغلت. One last thing, my program has like very diverse group of people. Some of them, a lot of them has like previous experiences. Do not compare your experience with their experience and do not assume that you know better because you did something before. Here, for me, it was like everything was different. That's my comment on this.
Any other questions from the audience? I don't see much questions. So I'll ask the panel a question. So when you start your internship and you start interacting with the nurses and the staff, sometimes nurses they have like they will ask you questions about like okay I want to do this or they will tell you like okay this is what happened with the patient overnight, what do you want me to do? Like you come in early and you are the first one who come in from your team and then you start seeing the patient and then the nurse approaches you and then starts saying well this is what happened last night and I think you should do this and this for this patient. So how do you deal with this kind of interaction when you are not sure, you don't know what to do, especially like I will give you an example. Like I started my ICU rotation and then I came in like so early, like maybe 5 or 6 in the morning. And then the nurse, she was like, oh, this patient's potassium is low. It's a 3.4. I want to give him like 40 milliequivalent of potassium. Is that okay? So, and I don't know what's going on. I don't know what's potassium. I don't know what milliequivalent is. I don't know if it should be PO or IV. No idea. So how do you approach these situations? Maybe Majdi can answer us. It's a question about potassium. He's going to nephrology.
Okay, so first of all, very good question. Let me tell you why. Nurses, especially the experienced ones, they know best. I can tell you when I started ICU, I did not know anything about ICU specifically the details, the vent, the gas, the whole thing. So whatever the nurse tells you, especially the experienced ICU ones, and most of the ones in the ICU have been there like for a while, she'll know exactly what to do. Sometimes I'll even tell her, just put the order under my name. Now, obviously, you're going to learn. And once you learn, you'll know how to replace potassium. You'll know how to do all these things. But if it's like your first time, nurses are your best friend. And you know who else is your best friend? Pharmacy. I cannot tell you how many times that I don't know the dose for certain medications. And when I first started, that I just call the pharmacist. And I tell him, hello, I have a patient that I want to order 1, 2, 3. Can you please help me with the dosing? Or what's the recommended dose for this medication? And the pharmacist and the nurses, especially when it comes to medications, especially in ICU, they're your best friends and you can learn a lot from them. Sometimes the nurse will tell you, Doc, I think this patient needs to be intubated. And from experience, they know because they've seen it multiple times. So that would be my best recommendation as you're starting. But obviously, you're going to learn these things with time and always the apps and everything. So I think that would be my answer.
الله يعطيك العافية.
أنا
هي
عندي
سؤال ثاني.
سؤال.
Yeah, go ahead.
How you can protect yourself and إذا إجت الممرضة وصارت تحاول to control you especially إنه أنت intern كيف ممكن تبين إنه أنت عم تحترمها بنفس الوقت تحمي حالك وتاخذ وقت لتفكر بالشيء اللي عم تسألك إياه؟
I'll answer this one. Since I don't know what she wants, what she specifically, as Dr. Muhammad Sayed mentioned, like we don't know how to give the potassium. I would always say I will check with my senior. There's nothing wrong with this. I will check with my senior and I will let you know as soon as possible. Do not do something that you're not comfortable with. Say, okay, I appreciate that, unless it's urgent. If urgent, it's kind of like patient is a rapid response thing, like just do because they're the expert. But in terms of protecting yourself, just tell her, I will check with my senior. And usually there will be always senior around you and you can always check. And then you can reply back. That's my own approach, honestly.
My 2 cents is if you are not sure, you're not comfortable with something that is specifically related to patient care and medications and orders, don't do it unless you confirm. You don't want to, have anything wrong. Now, if they ask you, oh, can I get an order for whatever lab, or okay, I'm missing some sort of an order, that's fine. It's okay, but it's completely fine, as was mentioned. Hey, I just want to check with my senior or attending or whoever. If it's urgent, pick up the phone and call the senior or the attending. But there is no room for anybody to intimidate you to do something that you're not comfortable with. I would just put it this way, because at the end of the day, it's patient care and it's you on the line. And if you're doing something you're not comfortable, it's on you. They're not going to go to the nurse and tell the nurse, why you told him to do that. You know what I mean? So just keep that in mind, obviously in a very respectful and a professional way. And always, always, always come back and follow up, like, hey, I just want to check with so and so, and I'll let you know, and then go back and follow up. And then you will gain their respect. They will respect you in the future. They will trust you. In the first couple months, there's always this kind of, the nurses, yes, they are experienced and you're new. So there is always that feeling, they might be aggressive, but everybody wants to do good patient care. So it's okay, but just, make it in a respectful and professional way, and always double check. It's completely fine. You're there to learn. And always remember, you're acting under the license of your attending. The last thing your attending wants you to do is to do something you're not comfortable, you're not sure about, because, if this results in a harm or some sort of, bad outcome, then your attending is also liable and will not be happy about that.
Yes, Clement.
Okay, there's another question. Omar is asking that he used to make plans and act on them before even the attending is available in Saudi Arabia. Should he continue with the same way, or he should just absorb and observe during the first few months? So what is your suggestion? So would that be considered an initiative, or would you prefer that? Or should he avoid doing that? So what do you guys think?
Look, at the beginning, there will be senior in the team. There will all be senior in the team. So if there's something urgent, just tell them. And of course, they should also know about that urgency, if I should say. and they will act on it. Do not act on yourself based on like your own judgment. Even if it's right, just communicate it, because at the end of the day, like at least in my program, the first 6 months, seniors are responsible of executing plans. If there's something missing in the plans, they will be like the one who's responsible for that. You should help, but you should communicate, but do not act on your own. Now that I'm like like 3 months, 3 weeks until I become like a PGY2, I can anticipate that this patient need discharge summary. I can do the mid rec. I can like finish everything done before the round. If I receive a patient with like a follow-up from the night team, like an admission from the night, and the troponin is like getting higher and higher, and now his troponin, like, let's say 50K, I do not have to wait now. I can just tell myself, hey, I'm calling cardiology, and I will call them right after. Of course, sometimes they will yell at you if there's no EKG changes, because this is, but I mean, like, you will get comfortable by time, but for the first 6 months, just ask your senior and do the plan based on their opinion. Do not act on your own.
Yeah. I think the key word is communication. And there are a lot of ways to communicate with the staff, with the nurses. A lot of people they like texting. Some people they use the epic chat messages. So just communicate. And even if you're sure about what you're doing, like you think that the patient needs antibiotics, even if you start antibiotics, just send a message to your senior and say, hey, I think the patient is having a fever, high white count. I started antibiotics, just confirming with you that it's okay. Just communicate. And as long as you communicate, if they say no, you shouldn't, then just stop it immediately. That's okay. I mean, and even if it takes like few minutes to respond, then that's okay. I mean, you can always cancel it, as long as you're not doing anything dangerous. If you're not sure, then don't do it. Just wait. It's okay. And in the hospital, I mean, nobody will die if you don't give the antibiotics in the first hour. I mean, unless it's really meningitis or something. But otherwise, in the first hour or two, I mean, in that time, you can always communicate and ask questions, and people will tell you if it's okay or not. So you have time. Okay. So I think I don't know. I think we're done with the session for today. I don't think we have any more questions so far, and I think we can conclude. Is that okay, Abdelkader?
Yeah. I think we're good. I just want to say a huge thank you to behind the scene team, Hussam Kiwan, Abdul Jalil, Al Raghib, and Hussein Hwaja. I hope I didn't miss anybody. These guys had a lot of work behind the scenes, so thank you, everyone. I know Hussam should have been with us, but he had to cover the hospital this weekend, so he was not able to join. But thank you, everyone. Yeah, thank you, Muhammad, for moderating and running this session.
Of course. And inshallah, we'll see you guys again next year, inshallah, giving us lectures and teaching us about your experience in internship and residency, inshallah. Thank you, everyone, who enjoy the rest of your weekend, and we'll see you guys again tomorrow, inshallah. Assalamu alaikum.
Thank you so much.